hyperglycemia, and we've heard already from David and others how impactful that may be. But do not forget what is also happening when it comes to the lipid profile as well as the blood pressure. So we can see that the metabolic complications of surgery significantly reduces, or rather the metabolic complications after surgery significantly reduces. But it's really the impact that we see on inflammation that is the most striking. And although my medical treatments are very good at weight loss, the impact that we can have on inflammation is not as profound as we see after surgery. And just to remind you, it's not only inflammation as measured in plasma, but also inflammation as measured in urine. So it's the inflammation that pertains to the organs that we want to be treating. And that is what was set out by Ricardo Cohen and colleagues when they did the microvascular outcomes of metabolic surgery study, taking 100 patients who had established type 2 diabetes and established kidney disease. So these patients both had obesity, diabetes, and kidney disease. I randomized them to best medical treatment or surgery plus best medical treatment. And this is, I think, what the future will have. We already heard about reoperations that we need to do, and that will always remain the case. But what we don't want is reoperations to be killing primary operations. Because if you have to do a lot of reoperations, we will not have the opportunity to do more primary operations, which is really the most life-saving of interventions. So how can we actually make surgery better? And the way to make it better is to add medications that's going to reduce the metabolic complications even further. And that is what Ricardo Cohen did here in these very difficult patients with obesity, diabetes, and established chronic kidney disease. And what he showed on the left-hand side is that, yes, medical treatments, the best medical treatment group is very good, and our medical treatments are getting better all the time. So more than 50% of patients with chronic kidney disease could be placed into remission. And we now know with our medical treatments, we can also place a lot of patients into glycemic remission. But look what happens if we combine surgery plus medicine. More than 80% of patients were suddenly placed into remission. And if you can see on the right-hand side, the marker of urine albumin creatinine ratio, which is a marker of kidney damage, is improved after the best medical treatment, but even more so after the combination of bypass plus the best medical treatment. So why does that happen? Why is surgery so good? And if we now take these operations and we go into a rodent model who have diabetes and chronic kidney disease, we can see that we can mimic the effects of surgery. We can improve glycemia, we can improve weight, but you can also see on the right-hand side, we can reduce urine albumin creatinine ratio. But how does surgery do that? And it's when we actually look into the histology of the kidney that we can see that surgery is reducing the inflammation and the stress on the glomerulus. So it is treating the disease in the place where it can have most impact. And when we dive even deeper using electron microscopy, you can see on the right-hand side at the top of the four, you can see what a normal kidney should be looking like. And you can see those little fingers that's sticking out. Those are the podocytes, and they are protecting the kidney from leaking protein. On the right-hand side, you can see that the black blobs that are there, that is the destroyed podocytes, and that is what's happening if we don't use surgical treatment. But you can see at the bottom left-hand side that those podocytes have been restored after bariatric surgery. Those little fingers are pointing into the lumen and is protecting the kidney from leaking albumin. So we can see that the mechanisms of how surgery is working is by improving metabolism, by reducing the metabolic complications such as inflammation, hyperglycemia, hypertension, dyslipidemia. But ultimately what it's doing is it's restoring organ function by restoring organ anatomy, as illustrated here in the kidneys. Now, can we achieve all of this with just weight loss and our medical treatments? And when we look at rodents where we have exactly the same weight loss and we match the metabolic benefits, we compare that with surgery, now we can see that there's still different pathways. The fingerprint, the proteomic, lipidomic, and metabolomic and genomic fingerprint of surgery shows us that it is doing something different to our medications. Now that's very positive because it means that surgery can make a unique contribution to reducing the metabolic complications, but it also suggests to us that there's real benefits in combining surgery plus medicine. So surgery plus medicine are going to work on different mechanisms using different pathways, and therefore is likely to be additive at a minimum to reduce metabolic complications before. And what David has shown you very clearly, and what has also been shown in the SORAC study from the Swedish registry, is that even when we treat people with bariatric surgery and we put their diabetes into remission, we do not reduce their risks as much as the population out there that do not have obesity. So therefore, yes, we are doing a great job in reducing risk of patients if we do bariatric surgery, but we're not doing enough. Those patients are still at higher risks than the populations that do not have obesity. And therefore, it is now the opportunity for us to do more and reduce those patients' risk back to the background population. And that is the opportunity for surgery, is to work with medicine to turn people back to normal, which I think can only be done if we use surgery, but also in combination with treatments. So I'm going to conclude and suggest that metabolic surgery improves the metabolic micromilieu. Surgery can address complications of obesity and diabetes. And now I think it's time for us to change our minds that we should be using surgery not for weight loss, but we should be using surgery for health gain. Please allow me to thank the team at home that's doing the hard work, especially Helen Heenahan, who is leading our surgical team, as well as our international collaborators. Thank you very much.
Thanks a lot. We're moving to the last talk this session by Dr. Ali Amini. Dr. Ali is an academic bariatric and laparoscopic surgeon in Cleveland Clinic. He's a director of Bariatric and Metabolic Institute. He participated and published a lot of a well-respected journal. Dr. Ali is a co-author of the well-known SASMBS paper that was done with Dr. Filshauer. Dr. Ali, the mic is yours.
Thank you, Mohammed. Can you see my slide?
Yep.
Okay, thanks so much for kind introduction and the invitation. In the next 10-15 minutes, I'm going to briefly discuss about the cardiovascular outcomes of bariatric and metabolic surgery. So fortunately, Dr. Cummins shared many of my slides, so that made my life easy. So we know that, unfortunately, in the United States, 40% of people with obesity and 10% have severe obesity, and only in the United States, over 100 million people have diabetes and prediabetes. And we know that all these chronic conditions can affect almost all organ body systems. The prevalence of obesity and being overweight is getting worse in every single country in the past 2 or 3 decades. Currently, worldwide, over 2 billion people live with obesity or being overweight. And we know that obesity is a major risk factor for cardiovascular disease. As abdominal obesity is as strong as hypertension, diabetes, and smoking to increase the risk of myocardial infarction. You see here that the odds ratio of developing myocardial infarction is about 2 points higher in people who smoke or have diabetes or have hypertension. But if the patient has all of these conditions plus obesity, the risk of having myocardial infarction could be 21 times higher. Obesity can increase risk of mortality, morbidity and mortality both in men and women, and it is associated with reduction in life expectancy in patients with severe obesity. In male, the life expectancy is about 9 years less compared to people with normal body weight, and in women is about 8 years less. We know that obesity can increase the risk of heart failure, stroke is associated with different types of cancers, and we have this constellation of risk factors that can work together and increase the risk of cardiovascular disease, obesity, insulin resistance, dyslipidemia, and hypertension. So how bariatric surgery or metabolic surgery can help? As Dr. Cummings clearly showed, we have 12 randomized clinical trials that consistently show superiority of bariatric or metabolic surgery over lifestyle modification and medical management in patients with type 2 diabetes in inducing remission of diabetes or diabetes control. And one of those trials was conducted here at the clinic, Cleveland Clinic. It's called SASMBS trial. In SASMBS, 150 patients with type 2 diabetes and obesity were randomized to 3 arms: sleeve gastrectomy, gastric bypass, and intensive life modification. And over 5 years after randomization, both surgical groups were superior to the medical group in terms of reduction in HbA1c and body mass index. Quality of life improved much better in the surgical groups compared with the medical group. The other randomized trial that can provide long-term data comes from Italy. Dr. Robino and Mingroni recently published 10-year outcomes of their trial, small trial, 60 patients who were randomized to 3 arms, open BPD, laparoscopic gastric bypass, and 20 patients in the medical arm. And as you see here, both surgical procedures were superior to the medical therapy in terms of reduction in A1C and weight loss. And the difference between the BPD and gastric bypass was not significant in terms of weight loss and glycemic control. Surgical patients had lower rate of diabetes-related complication at the end of their study, but the quality of life was better after gastric bypass compared with the BPD. BPD patient had, many of the patients had nutritional problems and frequent bowel movement, and that's why the author suggested that gastric bypass could be a better option, surgical option compared with the BPD, compared with malabsorptive procedures in patients with type 2 diabetes. Is better tolerated procedure, gastric bypass, than malabsorptive procedures. And the other randomized trial that can provide 5-year data was conducted in University of Minnesota diabetes surgery study. Again, 120 patients were randomized to 2 arms, gastric bypass, lifestyle modification. Findings were consistent with the other trials. Gastric bypass was better than the lifestyle modification. Dr. Cummings showed that slide. If we put the data of all these randomized clinical trials together to do the meta-analysis, the odds of achieving main glycemic endpoint was 8 times higher, favoring bariatric surgery compared with the medical group. And the mean difference in the HbA1c was 1.1% better, favoring bariatric surgery compared with the medical therapy. We know that the effect of the surgery is not purely weight loss dependent. Weight independent mechanisms are also involved. And as Dr. Cummings clearly showed, we have more than 35 large observational studies that can consistently show superiority of bariatric surgery in terms of reduction in mortality, especially in patients with type 2 diabetes. And Dr. Cummings showed the results of his meta-analysis that was published a few weeks ago in the Lancet. Among those 35 studies that we have, they selected 16 studies in their meta-analysis that fulfilled that criteria. And the result was astonishing, near 50% lower risk of death after surgery compared with the usual care. And the median life expectancy that patient can gain after surgery is about 6 years. So we do surgery and patient can gain 6 years additional life. And in the findings or the impact was more pronounced in patient with diabetes. If we operate in patient with type 2 diabetes, patient can gain 9 years of additional life. And in patient without diabetes, patient can enjoy 5 years of additional life after the surgery. And number need to treat to prevent 1 death in patient with diabetes in a 10-year time span was 8. When we operate on 8 patients, in a 10-year period, we can save 1 life. That was remarkable. One of those studies was published here or conducted here at the clinic, and we published the findings 2 years ago in JAMA. And briefly, 2,200 patients, 2,200 patients with obesity and type 2 diabetes who had bariatric surgery at the Cleveland Clinic were identified and they were matched to over 11,000 patients who received their usual care receive usual care for their diabetes at the clinic, and we followed them over the course of 8 years. In the surgical group, the most common procedure were gastric bypass and sleeve gastrectomy. And as you see here, the risk of major adverse cardiovascular outcome was significantly lower in the surgical group, 30% versus 47%, 39% lower risk of major adverse cardiovascular outcome in the surgical group. All-cause mortality, 41% lower in the surgical group compared with the medical group in the time span of 8 years. Heart failure, significantly low risk of heart failure, 62% favoring metabolic surgery, 31% favoring coronary artery disease, and 33% favoring cerebrovascular disease in the metabolic surgery group compared with the usual care. The impact on the nephropathy was remarkable, 60% low risk of nephropathy after the surgery compared with the usual care and atrial fibrillation. So surgical patients lost more weight. Their A1C was lower by 1.1% at the end of the study compared with the non-surgical control. They required less insulin and less non-insulin medications to take care of their diabetes. Their blood pressure and their lipid-lowering medications significantly less in the surgical arm over the course of a study compared with the usual care. But all of this, the data that I showed you comes from the cohort, and we cannot apply that to a single patient. When we have a patient in the clinic, the way that we can apply these findings in the single patient would be very important. And that's why we decided to develop predictive models to predict the risk of end organ complication of diabetes without metabolic surgery. And by having that, we can use the data of this large cohort and apply it to a single individual to give the patient an objective information about the risk and benefit of the surgery. So these risk calculators are available on the ASMBS website. As you see the link here, asmbs.org/escape diabetes, or on the Cleveland Clinic website, riskcalc.org, or you can download the app from the App Store. It's called Bariatric Calc. You can put patient information in the calculator, and calculator will calculate or estimate the risk and benefit of surgery. For example, you have a patient who is 62-year-old man with BMI of 36, African-American, never smoked, patient had history of high blood pressure, cerebrovascular disease, and nephropathy. You enter the blood pressure, HbA1c, creatinine, and triglyceride data into the calculator. This patient is on metformin, on antihypertensive medication, and aspirin. And the calculator going to calculate the risk of individualized risk of end organ complications of diabetes in this particular patient over the course of 10 years with usual care versus bariatric surgery. For this particular patient, if the patient continue with the same care, the 10-year risk of dying would be 34%. And if the patient gets the surgery, that risk drops to 21%. So that means 13% lower absolute reduction in 10-year risk of dying. We can tell patient that your 10-year risk of dying would be 38% lower after metabolic surgery. For heart failure, if the patient continues with the same medication, same trend, 10-year risk of dying would be about 42%. If the patient gets the surgery, the risk of developing heart failure would be about 18% in 10 years. We can tell patient that 10-year risk of developing heart failure for you would be 58% lower after metabolic surgery. Coronary artery disease, 18% with usual care versus 14% after metabolic surgery in a 10-year time span. So 10-year risk of coronary artery disease would be 22% lower after metabolic surgery. Since this patient already had history of a stroke and nephropathy, the calculator does not recalculate those. But if the patient did not have those, the calculator could provide the risk of those complications as well with and without metabolic surgery. And then it can generate this visual report for the patient that can be more understandable. It shows 10-year outcomes for 100 people like you with or without metabolic surgery. So we talked about the efficacy. Now I'm going to briefly talk about the safety. And we are almost all of us are surgeons, and we know that how safe bariatric and metabolic surgery is. So this study was done a few years ago, and we compared the safety or the risk of early complications of different surgical procedures in the American College of Surgeons database. And as you see here, the gastric bypass was, in terms of the early post-op complications, was comparable to hysterectomy and cholecystectomy and was safer than appendectomy, colectomy, or CABG or vascular bypass procedure. So it does make sense to do the gastric bypass or sleeve gastrectomy or metabolic surgery to treat diabetes and decrease the risk of complications of diabetes in order to prevent doing those morbid cardiovascular surgical procedures. And Dr. Cummings showed that the mortality of the gastric bypass is comparable to arthroplasty and hysterectomy, much less than the other procedures, including cholecystectomy, colectomy, or CABG. Currently, we know that the sleeve gastrectomy is even safer than the gastric bypass with the rate of about 1 in 1,000 patients. So for that particular patients that I presented to you, if we decide to calculate the risk of the procedure, we can use different risk calculators, including the MBSA-CoIP risk calculator or risk calculator at the Cleveland Clinic. For that particular patient, a sleeve gastrectomy would be a good choice. If we put the patient information in the calculator, the estimated probability of serious adverse event after a sleeve would be about 3% for that particular patient. Now, we have objective data to present to patient. So we can sit with the patient and talk to the patient. So we can say, Mr. Jones, here is your information. So here is the objective data. Risk of serious adverse event after a sleeve gastrectomy would be about 3%. And if you get the sleeve in 10-year time span, you will have 38% lower risk of death. You will have 58% lower risk of developing heart failure and 22% lower risk of coronary disease. So 3% lower risk, 30% risk of adverse event versus these benefits that you may gain in 10 years. Again, these calculators are available on the website and as app. So take-home message: in patients with obesity and diabetes, metabolic surgery is extremely safe, extremely effective in achieving weight loss, diabetes control, and lowering the risk of end organ complications of obesity and type 2 diabetes, and improving the survival. And these calculators, including the Cleveland Clinic calculators, can provide individualized estimate in risk and benefit of metabolic surgery and can be used to inform treatment decision for patients and practitioners who are considering surgery, especially in patients who are not sure about the risk and benefit of surgery. You can provide them convincing evidence about the risk and benefit of the surgery. Thank you very much for this opportunity.
Thanks, Ali. Great presentation. I was instructed by the organizing committee that to have not more than 5 minutes in the discussion. Meanwhile, I'll put some polling question. I'll start in number 1, then I'll go to my colleague panelists to discuss some question regarding the previous presented lectures. So kindly speakers and panelists, they could share their opinion in the coming question. So I'll post it for 30 seconds. Then we'll come back to the poll answer. It's number 1, I think. It is there. Is it there on the screen? What would it be your surgical approach in weight regain after one-wide gastric bypass, piliary limb elongation or distalization, then reversal bypass to sleeve gastrectomy, SADI, PVD? So I have a question here, I think for Dr. Carl Rolou. After bariatric surgery, the complication of microvascular and macrovascular reduce. As we know, patients have different reduction in weight loss. So what's the targeted PMI to achieve a reasonable reduction in micro and macrovascular diseases? The floor is open for.
So very good question. And what we see is that the percentage weight loss of 25% after surgery seems to be more than sufficient to have a dramatic improvement. But I think what we are now thinking about is, why can we not take somebody with a body mass index of 50 and turn them into a body mass index of 25? Now, that may not be possible with surgery alone, but now with the addition of medications such as semaglutide together with surgery, it may be possible that you can take a sleeve gastrectomy and turn it into the efficacy of a duodenal switch, or you can take a gastric bypass and add on another 10-20% weight loss. So I think this is going to really revolutionize, and this is what we do in cancer all the time, is we do surgery and we make the surgery even better by using chemoradiotherapy.
Thank you. So back to our poll. I think most of the voters, they vote for piliary limb elongation. I'd like to hear Dr. Shower opinion regarding this question. Prof. Shower, still with us? Dr. Awad from panelists.
At the beginning, sorry, I'm not sure if the Dr. Shower with us or not, but at the beginning, I start to do elongation of the elementary limb, but I see the results when I convert with elongation of piliary limb. I see there's a big difference regarding weight reduction. We did many cases and we got a good result, and we are soon will publish our result. If you go to the literature and look to it, I think they did many studies and they found there is the elongation of piliary limb is superior to elementary limb around 5%. It's not that significant, but in our experience, in our patient, in our revision cases, we see a big difference.
And how long the common channel that you will restrict to?
We go with, like, usually we are not reaching more than 250 piliary limb length, but we usually keep the common channel around 300, not less than 300, to stay away from malabsorption and multivitamin deficiency.
Dr. Ali?
May I say something, Dr. Muhammad?
Go ahead.
Yes, please. Malabsorptive procedure, in our experience, we have done more than 1,000 or 1,500 bilipancreatic diversion and we had a lot of metabolic complications. So in our revision, we aim to, according to Scopinaro's recommendation, our aim is to elongate the common limb. So he do 250 elementary limb and 50 common limb. So our aim is to increase the absorption capacity by increasing the common limb to 150. So total limb you will have 200 elementary and 200 common limb, so 450. But you have a large stomach. We have done all these revisions, and you have another revision is by increasing the to the ligament of tripes. So you will have almost total elongation or total revision by joining the elementary limb to the duodenum. So all these modalities of revision by increasing the common limb and the total limb from GI limb to increase the absorption capacity. But we have in biliopancreatic, we have the result that all the patients gain weight up to 70%, some of them to 100% weight regain after 1 year. So in our technique now, we have almost 25 to 30 patients we have done by adding resizing of the stomach. So we resize the stomach and we keep the total limb to 4.5 meters, 200 elementary, 250 elementary limb, and common limb 200. So total 450 with the resizing of the stomach. And our result going to be published soon. We have 30 patients and improve the metabolic complication and without weight regain for this patient. So it is a total limb not less than 400 to 450. Otherwise, you will have all the metabolic complications.
Thanks, Khalid. Dr. Ali Al-Aminian, any comment or any add-on to what
Yeah,
Dr.
so we need to be, yeah, I agree with other speakers and panelists. I think we need to be very conservative and very careful because we know that this procedure can increase the risk of malnutrition and we don't want to harm patients. So we are very conservative here at the clinic. So the total length of the alimentary limb plus common channel in our practice is around 450 to 500 centimeters. So if the patient has already a rule limb of or alimentary limb of 150 centimeter, we make the common channel not shorter than 300 centimeter to give patient 450 centimeter of total alimentary limb, which is the length of the rule limb plus the common channel. So the point is that we were more aggressive before, and we have had many patients with malnutrition, and now we are very conservative. So the length of the alimentary limb, total alimentary limb, which is rule limb plus common channel, is not shorter than 450 to 500 centimeter in our practice.
Here's the result of the vote. I think most of the voters vote for piliary limb elongation. Okay, we'll move to the second one. I think I have 3 questions here. The second one is regarding the complication of bariatric surgery. We know that pulmonary embolism or thromboembolic event is one of the known complications. So the question in a female patient with a BMI of 43 and a history of DVT and PE in a duration more than 6-month duration prior to her presentation to the bariatric clinic. She was scheduled for lap sleeve gastrectomy. Who will offer an IVC filter as a pre-op step before doing her bariatric procedure? So this is the question. What's your thought? Is Dr. Mifty with us? Dr.
Yes,
Adnan?
I am with you.
What's your thought about this case, Prof. Adnan?
We are not supposed to add, but female with 43 history. 8 months ago, she is scheduled for lap sleeve gastrectomy. Will you offer IVC filter? No, I won't.
With the history of, with the previous history of PE.
I know, but it is not a life issue, which means that there are thrombi in the IVC, and you want, or in the deep vein thrombosis of the lower limb, which is showering up. Keep her anticoagulated or on higher dose of prophylactic antithrombotic agents, and you can carry on with the sleeve gastrectomy.
I have a comment if I can.
Sure.
So if patient had PE 6 months ago, I wouldn't do surgery right now, elective surgery. I'm gonna wait at least 12 months to make sure that patient risk is low. And this particular patient probably gonna be on lifelong anticoagulation with the history of the PE. And probably we have to bridge, if the patient is on warfarin, we have to bridge that to the heparin, do the surgery, and then bridge it back to the warfarin. Most likely doesn't need the IVC, but 6 months ago PE, I probably not gonna do elective surgery.
Our cutoff period is 6 months. You used one year cutoff, which is another issue. Okay, thank you.
Just a quick Muhammad, we do that D-dimer. If the patient, the D-dimer is normal, then we can ask hematology for clearance. We did some cases like that, and they do well, actually. We look to the cause of the PE. If it's antiphospholipid syndrome, then we treat patient with dermatology and hematology, and then we come. IVC filter is I would call it old history now. High risk and high morbidity, and usually you keep it for trauma.
Okay. I see Dr. Ashraf Maghreb with us. Ashraf?
Then Muhammad.
Are you still with us? So what's your input in this?
I think I would go with the same with Dr. Awad mentioned. The patient should be evaluated for the cause of the PE and DVT. I doubt if the patient had one history time of PE that they will be lifelong anticoagulated. Rather, that will be a decision of a hematologist discussion. What I would add, though, is I would just do a Doppler scan as well, preoperative, and then we'll take it from there. If there is still active, probably a DVT or something, then we delay the surgery for probably another 6 months or so. But I will not place an IVC filter for such elective procedure. And of course, with a good anticoagulation and embolization intraoperative and so on and so forth.
I think most of the audience for attendee are in agreement on what we discussed. So about 79% of the vote not to place an IVC filter, and just only 21% to place an IVC filter. We're going to the third scenario. So this is a real patient of mine, and I won't tell what I did for her. She's a 43-year-old female with a BMI of 40, diabetic, hypertensive, end-stage renal disease. On hemodialysis, she's on the list for renal transplant, pending weight reduction. What would be the best procedure for her? Laparoscopic sleeve gastrectomy, Roux-en-Y gastric bypass, SADI, one anastomosis, or just go with endosurgery, endosleeve, or intragastric balloon? Prof. Adnan?
I will go for laparoscopic sleeve.
Okay, Khalid? You're mute, Khalid.
I will go for gastric bypass, and I have the reason for that because this patient lose weight, and if I do sleeve, we may need to reverse him back post renal transplant. We don't know. Sleeve is a permanent procedure, irreversible, so causes severe dehydration, severe metabolic complication, and this patient, if needs something to revise, we have the capacity or ability to reverse her from bypass to normal if we need. This is abnormal patient, high risk.
Awad? You're mute, Awad. Awad, you're mute.
Dr. Awad, yes.
Yeah, I will, sorry, I will do sleeve gastrectomy. We did around 15 cases. They do well. Risk of dehydration is high with other procedure, and also the absorption of medication like SASMBS is affecting by bypass.
Good. Dr. Ali?
I would go with the sleeve too. This patient is a high-risk patient. The sleeve provides the patient good diabetes control and weight loss. And we know that if we go with those rerouting procedure, any of those rerouting procedure, bypass, SADI, single anastomosis, switch, those can increase the risk of hyperoxaluria, and the patient get the kidney transplant. That hyperoxaluria may damage the transplanted kidney. That's a lower risk after the sleeve.
Thank you. I think we're in agreement, and this is what I did exactly for the patient. She underwent sleeve gastrectomy, and I think most of the vote, 80% of the attendee and the panelists, they vote for sleeve gastrectomy. I think this is the end of the session, and thank you for all the speakers, the panelists, and the audience for attending such great session. Now we have 5 minutes break, then we'll resume. Thank you very much.
Thanks, everyone.
Thank you.
Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way, by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future. Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way, by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
Good evening, everybody. Welcome you today for this session, and thanks for really all our speakers who really contributed a lot to this meeting, whether yesterday's session or today's session. Welcome you to our society, those international speakers, and thanks to local speakers and panelists. And we are glad to today to present our president, Professor Adnan Mufti. We have a lot to say, so we will be, let us see, it should be working very well, I guess. Professor Adnan Mufti is the first batch of KSU, King Saud University graduates in 1976. He's not that old, he's still young. And he did his training in the UK and in St. Mary Hospital. He finished there in 1982, then came back to Saudi Arabia. He started his professional career in King Saud University, King Khalid University Hospital. He started as registrar, senior registrar, consultant. Then he was the head of department at King Saud University. he continued there until he's a professor, full professor in the university. Then he moved to another institutions, which is security force. He was also the head of the department there. He developed the department and established very good career at security force, and promoted and shared significantly in the development of surgical specialties, general surgery and vascular surgery and otherwise in security force. Additionally, he contributed significantly to the development of residency training and Saudi Council of Health Specialties from the inception of the Saudi Council of Health Specialties. He is a member of many executive committees and boards, whether local or international, including the Pan-Arabs and other societies worldwide. He's a member of EFSO and SASMBS and MBS, and he's also active members in many meetings and many activities, scientific activities in the region and globally. And I guess he likes also to connect with his colleagues everywhere, whether in the scientific part or social part. And you can see a lot of nice dress for many people, Western. I guess they are part of our culture also. Dr. Mufti has been awarded many distinguished awards in his in the field of surgical specialties and also in the leadership management. So it's really a pleasure for me today to present our president to give his presidential speech, Professor Adnan.
Thank you, Professor Ayed. Thank you for this nice introduction. And may I share my screen, please?
You are on, Dr.
Yes,
Mufti.
I'm sharing my screen now. Yeah, it's coming. Be able to see it, yes. Okay, I've been asked to talk about the evolution of the metabolic and bariatric surgery in Saudi Arabia. Let me. Play. Yeah.
Press play, Dr.
Yeah,
Adnan.
yes,
Yeah.
that's it. We are on now. So I would say I am very honored and proud to start the practice of bariatric surgery in the Kingdom of Saudi Arabia since the 80s of the last century. It all started in during my fellowship training in UK at St. Mary's Hospital. This is a famous old hospital in London, Paddington. When I joined the surgical metabolic unit of St. Mary's Hospital, which was at that time under the direction and supervision of my mentor, Professor Hugh Dudley, who was also the chairman of the surgical department at St. Mary's Hospital. From this man, I did not only learn the practice of surgery, the skills of operating, but also I shared him some of his attitude and his manner and his commitment and dedication to the practice of surgery. So I'm very grateful for him. And from that time, I was attracted to the operating on the obese people. And fortunately, in '81, I joined Professor Dudley in one of the cases he was doing as a first assistant. The first assistant, because I was a registrar at that time, and he has a senior registrar who's much more qualified with me, but he rather asked me to join him because the patient was coming from Saudi Arabia to be operated up in London because there was nobody. She was a huge patient. Her name, I still remember her, was Zahra, but she were never been a Zahra by that age. She was bound to the wheelchair. and he did on her, I don't know why, but jejunal bypass. From that time, I was attracted to the practice of operating on obese people. When I came back again in '82 to Saudi Arabia and joined the medical school as an assistant professor of surgery and the senior registrar in the department, we attracted a famous professor of surgery from the St. Bartholomew's Hospital who was just retired, Gerald Taylor, a great man who after finished his job at St. Bartholomew's, he opted to join us here as a professor of surgery and the chairman of the Department of Surgery at King Khalid University Hospital. And all the older surgeon in the kingdom remember this man who was a great support to us. And he is the one who inspired and gave me the courage to start and practice the bariatric surgery at the era of the open surgery at that time. On 1984, we were stuck with Miss Zahra again, who came to us from the South region. Again, she was in a wheelchair in a horrible state. She was undernourished, malnourished, and all these things, and cannot walk because she was not taking any supplements. So we worked on her, and me with Professor Taylor, we opted to operate on her and refers the jejunal bypass for her. So we started our career or our with a revisional bariatric surgery, not with a virgin case. So we converted her to a VBG after we correcting her metabolic issue. After that, we started to accept more cases of obese people, and one of the people were his Miss Zahra's sister, who also we operated on her again, and we did a VBG, and this is her sister. This is the type of patient we used to do. And so we expanded our work to do more and more cases, and probably you know, with the help of our late Bassam Hawari, Allah yarhamu, he was also fascinated to convert those people to a very beautiful, acceptable patient for themselves and for the community. So he was doing all the reconstructive plastic work on our patient. And here you can see Professor Taylor in the middle, me operating, and this is the era of the open surgery, and you can see probably Nail Al-Khadairi and others, and probably also Professor Qasim Al-Qasabi was one of those watching. They were teasing us for operating on those patients for long period and with possible. It was only for this instrument where we were able to do the VBGs, and probably not many of our young colleagues recognize this picture or have seen this picture or been exposed to such picture of open bariatric surgery. And this is maybe unique to them, but this is just to show them how it is. So after that, in 1901, I went to Erlangen in Germany under Professor Kochring. I was trained to do how to do laparoscopic cholecystectomy. And by the end of 92, we were able to do more than 300 lap choles successfully and train others also on performing laparoscopic cholecystectomy. Doing a lot of that with some here, Dr. Khalid Al-Mutari, Dr. Late Dibaja, they were our those are Abdul Hamid Al-Mu'min, myself, Qasim Al-Qasabi, a lot of them, Khalid Bakhsh, Al-Asiri, so many of them. Then we were putting the lab band on by the open technique. Then in 98, I went to Liège, Belgium, under Professor Belache, where I trained to put the band laparoscopically. So then in 99, I went for a fellowship in minimally invasive, we call it nowadays, but it was laparoscopic surgery there, where did a fellowship in laparoscopic surgery at William Beaumont Hospital in Detroit, the Royal Oak campus. From 2000, we were doing advanced laparoscopic bariatric procedures. Also, there were others who were doing some laparoscopic procedure in Jeddah and in Riyadh, like Walid Bukhari and Atif Bassas in the military hospital. Those people were trained in Germany. So from the period of 84 till 2009, we at the King Khalid University Hospital and later at the Security Forces Hospital 2 or 3 years, we did more than 4,500 patients. Those were pure bariatric procedures. The demography is usual. This is the distribution of the cases, including the intragastric balloons, the open and the laparoscopic. And you can see that we did also a lot of sleeve at that time. All of them were laparoscopic cases. These are the arrangement for us. So this was in Riyadh. What happened in the Eastern Province is a different issue. Dr. Mu'min, who was with me in Riyadh, especially at the Security Forces Hospital, he left and he started to do the bariatric surgery under the mentorship of Carl Miller in the Eastern Province at the Saad Specialist Hospital. Also, there was Khalid Mirza, who was quite young at that time, and he has also, in collaboration with at Al Mani Hospital there, they started the gastric banding in 2002. And the Roux-en-Y gastric bypass started in 2005, and then started same period by Ahmed Al-Garza'i with Barini, and Khalid Mirza with Dr. Ahmed Salman in collaboration with Barini again in the National Guard. They did a lot. Our colleague Sultan Al-Timyat was an inventor, and he started in the Saad Hospital doing a lot of the bypass surgery. This is Al-Garza'i, and this is Sultan Al-Timyat. You recognize him. Roberto Tacchino helped us a lot to establish the program of Roux-en-Y gastric bypass, where he continued in the King Fahd military medical city and the National Guard in Eastern Province. And they did a lot of it. Khalid Mirza with Ahmed Salman, they opted to do the BBD, the Scobinaro procedure, and they started to do a lot of cases in that area. So most of the people in Al-Hassa region, Al-Khubara, they underwent the BBD procedure at that time. The sleeve gastrectomy started a little bit later on 2006 there, or 7, where it was popularized with Ahmed Al-Garza'i with his medical or surgical team in the military hospital, to the extent that they start to do the single incision sleeve gastrectomy by 2010. So also they started the nucleus for some academic background or academic activities in a form of the Eastern Province Obesity Club. This was started from 2007 and shared by different surgeons of the group, by Ahmed Al-Garza'i, Khalid Mirza, Sultan, and so on. And they also filed document to present it to the Saudi Council to formulate the Saudi Obesity Society. This is the original name of our SASMBS, the Saudi Obesity Society, in 2010. In the Western region, the bariatric surgery has a different story. They started even just with us in 1984. There was sporadic cases of bariatric procedure at the Thagr Hospital. At that time, Walid Bukhari, who is our very senior and very famous bariatric surgeon, was a resident in surgery at that time. Dr. Amar Tawfiq, Fagi Basili, Suleiman Ibrahim, they were all at the King Fahad General Hospital in Jeddah, and they were doing sporadic cases or occasional cases. But by 1992, Walid Bukhari was back from Germany in Jeddah, and he started to do some bariatric cases in the private sector in the Salam Hospital and the Thagr Hospital after that. So he started in 1992 and then followed up in 1994, where he started to do laparoscopic gastric banding. The big change in Jeddah happened when Walid Bukhari has transferred in 1996 to King Fahad General Hospital. And there he started to do more cases, and he got a lot of support, especially when he was joined by Mahmoud Hammu, our Sudanese colleague who spent most of his life with us in Saudi Arabia. From 2000, he is with us, and they did a lot of cases. By the end of 2001, they did more than 2,500 cases. And that after they established a center for laparoscopy at King Fahad General Hospital. They call it Prince Sultan Center for Advanced Laparoscopic Surgery. And here you can see the inauguration ceremony with the director of the hospital and his deputy, and Prince Sultan, Allah yarhamu. So, to start with, we can say that the old gang of surgeons in bariatric, apart from the one in the Eastern Province, Walid Bukhari in Jeddah, myself here in Riyadh, and then when I left from the university to the Security Forces Hospital, Abdullah Dahayan took over there. Those who started our obesity group were Sultan al-Timyat in 2010 with Walid Abu Milha, who is a family practice consultant, and then with his colleague Garzai and Khalid, they established the obesity club in 2007. We are very grateful and appreciative to Professor Malfobi, who helped us from the IFSO meeting in Capri from 2008 to be a member of IFSO as a chapter, as a Saudi chapter. At that time, we were not established as a society even. But in 2008, we were recognized as a chapter of IFSO in that meeting by the help of and support of Professor Malfobi. Our society was established in 2009, in 29 of August 2009, and this is the decree of establishment of our society under the sponsorship of our Saudi Commission for Health Specialties, which is responsible for all or most of the professional societies like ours. These are the people who established the society. Sultan al-Timyat from the Eastern Province, Walid Abu Milha, who is, I said, a family practice man from Asir, Ahmed al-Garzai from Sharqiya, Salih al-Rajhi from Riyadh, and Al-Hassan al-Guud from Asir. Those were 5. They are the real pioneer who established our society, according to the decree from the Council of Ministers in Saudi Arabia. This was the board members of the first team, and was shared by Walid Abu Milha, and Sultan Al-Timyat was his deputy with other member. And you can see that most of the members were belonging to the family medicine specialty. In 2011, our society was named as Saudi Arabian Society for Metabolic and Bariatric Surgery. And this is a board member of the second term. Still, Abu Milha was the chairman, and the deputy was replaced from Sultan by Khalid Mirza, who took over. Then the bariatric surgery activity during this period, but the metabolic surgery and thing, was a lot of activity going on. In 2012, there was Khalid Mirza organized the metabolic surgery for diabetes. Revisional bariatric surgery was organized in Jeddah in 2013 by Walid Bukhari. Bariatric and metabolic surgery, the complication were organized by our colleague, senior colleague Abdullah Zahrani in Riyadh Military Hospital. Bariatric and metabolic surgery activity for bariatric surgery, the future, and that was organized in the Asir region by Muhammad Bawahab, the chairman of the previous session, or the moderator in our previous session, who was also one of the senior bariatric surgeons in the region. Other pioneers in that, Atif Bassas, who was with us here in Riyadh, who started the Roux-en-Y gastric bypass, especially, and laparoscopic VBG also in the military hospital. Aida Al-Gahtani, in 2002, he was the pioneer and the first one to start bariatric surgery on children, on pediatric. Also, he's a world or international expert now from 2016 on endobariatric or endoscopic bariatric procedure. Ali Mani Al-Ahmari in Asir. Bawahab, as I mentioned. Haider Al-Shurafa with Atif Bassas in the military hospital. Those are those who started the bariatric surgery in the region from the early 90s. And this is the laparoscopic society, which is under the University of King Saud. And here you can see me with Abdullah Dahayan and Walid Bukhari. Also, we are active member in this society. This is board members of the current term, which will end in November 2021. I am honored to be the chairman of this board, with Khalid Mirza, my deputy, and all the other members, and with our active and energetic Ali Al-Muntashiri, our Secretary General, and the others who are sharing all the active committee who is working for this society. Our growth started from 2009 by 20 members, and now we are more than 200 members, active members in the society, between mostly surgeons. The same thing happening with the incidence of obesity in the kingdom. From 91, we were less than 20, and now we are unfortunately more than 30% in the incident of, and it is still growing, and it is not even leveling up. We are in good collaboration with the EFSU, the World Obesity, the Gulf Obesity and Metabolic Surgery Society. We are also in collaboration with the Obesity Society, as well as with the Pan-Arab Society for Metabolic and Bariatric Surgery. And we hope to get involved with others. Thank you very much. I hope that I did not forget many. I am sure I left a lot of the pioneer and those who contributed to the surface of bariatric surgery in the kingdom. And currently we are working mostly to work on the prevention as well as the treatment of those who are obese in order to.
Thank you.
Thank you.
Thank you, Prof. Adnan. It's really a great talk, and you went through a lot of historical background of our development, the society development. Sure, again, in virtual, in a real life, we'll be having a stage to give you some appreciation of leading the society, but consider it done, and we will move to another stage or the other talk. So it's a pleasure to call upon Dr. Ahmed Al-Karzai to run the next session. How do I see and do certain procedure and certain issues in our practice? Dr. Ahmed Al-Karzai.
Assalamu alaikum wa rahmatullahi wa barakatuh. Do you hear me well?
Yes, we hear you.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, alhamdulillah wa salatu wa salam ala rasulillah. We thank you, Professor Ayil, for an excellent organizing and chairing this international congress for the SASMBS. And our thanks extended for Professor Adnan Mufti, the chairman of the society. Because we are in behind of time, Bismillah ar-Rahman ar-Rahim, we are going to start this session, how I see and how I do. We have in this session a distinguished panelist. And if I go through my colleagues, Dr. Haytham Al-Falah is a well-known bariatric surgeon. He's the chairman of general surgery in Kingdom Hospital. He was the CEO of King Saud Medical City, and he's the founder for Bariatric Surgery Center Program in Ministry of Health. He contributes a lot for bariatric surgery in Saudi Arabia. Second, my colleague, Dr. Ali Mani Al-Ahmari, and he's one of the first pioneers who started bariatric surgery in Southern area, founder in the first round of Saudi Laparoscopic Society, and also founder in the Gulf Bariatric Surgery Society. Dr. Abdurrahman Al-Saigh, one of the earliest surgeon in Riyadh area, bariatric surgeon since the 90s and in the 2000s, and he have many participation in congresses and publication. Dr. Mahmoud Sadiqa, one of the leaders of bariatric surgeon in Jeddah. Mahmoud is a board member in the SASMBS, and he's a leader in Ministry of Health for bariatric surgery in Jeddah. And my dear colleague, Dr. Mohammed Al-Aqil, a bariatric surgeon and laparoscopic. He's a leader for bariatric surgery program centers in Ministry of Health. And he was the head of bariatric surgery in King Saud Medical City. To start the session, we would like to invite our colleague, Dr. Khalid Mirza. Khalid is the Deputy Vice President of the Saudi Society for Bariatric Surgery, and he is the chairman of the IFSO MENA chapter. Khalid, one of the leaders of bariatric surgery in Saudi Arabia and Eastern Province, has been presented by Professor Adnan. And Dr. Khalid, he is going to present how to augment bariatric surgery in weight reduction or lose with pharmacotherapy. Dr. Khalid, please, the floor is for you.
Okay, thank you, my colleague, and for all of you. I will share my presentation. Is it okay now? Is it shared? You can see me?
Yes, we can hear you very well.
Not,
the presentation not appear. We need to see the presentation.
Okay. Now you can see?
Yes, Can we have it full screen, sir?
Now,
Yes, please.
I think my presentation will be a continuation of what of yesterday talks and today for all my colleagues before me. Now, if we talk about GI mechanism of metabolic regulation, this slide was shown by my colleague about body weight glucose metabolism, and on the left side, on the right side, mechanism of action. It is a very complex technique and mechanism integrated between the old GI tract to regulate metabolic and obesity. So many hormones involved, bile and neurological reflex, all these get involved in controlling the diabetes. So most important thing in obesity pathophysiology and pathology is hunger first.
Can you increase your phone?
Oh, my voice now is okay.
Still low. We need the higher, please.
I can shout more, no problem. Okay, can you, the most important mechanism here is the patient which makes them fail to continue diet is the hunger. It is the most stimulating factor in their obesity and which change their habit of eating. It's the hunger pain. This is why they cannot tolerate and continue diet. And which cause increasing calorie intake, lead to obesity, fatty liver, and insulin resistance. In the other side, we have to cut this cycle by surgery, restrictive surgery to reduce the feeling of hunger, or malabsorptive by acting, decrease the hunger pain and decrease the calorie intake, which is malabsorptive procedure. And the other mechanism, it is a GLP-1 agonist, which through the mechanism of beta cell function and lead to control the obesity. So we have current target for anti-obesity medication in the market. We focus in Saudi Arabia. We have the Olistat and we have the liraglutide 3 milligram, which is approved by FDA and Saudi FDA. This is the two medication available in Saudi Arabia. So the mechanism of action, as we said, it is liraglutide GLP-1 activate area of brain involving in appetite and regulation, which is reduce the hunger and increases satiety. So these drugs can help in patients for continue diet and get benefit from continuing diet, and they lose weight. So as I mentioned, most of the problem of these patients is the feeling hunger. And if we have such a drug which controls the hunger and increases satiety, it will work perfect. So if we go, as we mentioned, as we heard from our colleagues before, bariatric surgery is elective. Elective, that means it should be safe. So preoperative optimization must, this is all the guidelines and protocols. We have to optimize the obesity, obese patient preoperative. We have to optimize their condition. We have to control their metabolic syndrome, diabetes, hypertension, dyslipidemia, vitamin deficiencies, H. pylori, all these we should be optimized before we do surgery. This will reduce the postoperative complication. So one of these also risk factors is BMI, preoperative weight loss. This is one of the recommendation of the ERAS system, which was mentioned yesterday by our colleagues. So weight loss, preoperative weight loss, or downgrading BMI will reduce the postoperative complication, and you will give us more weight loss post-operative as a parameter. We just heard it before, 2 lectures before today. So other risk factors we have to control: prophylaxis, VTA, infection, other preventable complication. So it is avoidable. So as we mentioned, we look for one of the important factors which lead to more complications in this paper, that morbidity and mortality increases on predictable trend with the increased age and BMI. If we focus on BMI, all of us, we are surgeons, we find that the BMI, as much as the BMI go up, that the complication, interruptive or post-operative complication risk is higher. So like ICU, hospital stay, mobilization, DVT, intraoperative injury. So BMI is one important factor to be controlled. So if we lose weight, whatever percentage, 0 to 5, 5 to 10%, 10 to 15%, up to more than 15%, this will reflect on the general condition of the patient. Our colleagues before me, this early hour, they mentioned about the effectiveness of weight loss. Even 5% weight loss will improve your hypertension, hyperglycemia. 10% will improve more your comorbidities. So the effectiveness of weight loss, even if it's 5%, it will be appreciated and valuable for the patient. So we have to think about as a part of the preoperative care, preoperative assessment or requirement to think about weight loss because it is very effective in the preventive of complication. Preoperative weight loss may improve the postoperative outcome. This study which shows that shorter length of hospital stay and early mobilization and improve the respiratory and cardiovascular system. So again, preoperative weight loss improve postoperative outcome by greater postoperative weight loss. If you start patient with BMI 55 or 53 and you downgrade him to 50 and you do the surgery, his weight loss will be better. And this was clearly explained by my colleagues before me. So if you patient behave preoperative and he compliant with weight loss, he will behave more and his outcome in weight and excess weight loss will be better. So it is clear from my colleague in many studies. Again, preoperative weight loss will give you fewer postoperative complications. Early mobilization, this is a very good for DVT and a good respiratory function. Avoid the ICU and overnight observation in ICU or excessive oxygen use. So if we talk about liraglutide, one of these medications approved here is effective adjustable in weight loss in patients with prior surgery. For the long term, as many as 10 to 20% patients regain of all the weight lost through the surgery. We know that in many studies. So we have to think about something preoperative, and even we have to use something post-surgical or augmenting post-surgical weight loss. If we think about effective liraglutide for preoperative weight loss, yes, liraglutide is effective. So many studies, it will augment the weight loss and also increase the excess weight loss post-operative, and also pre-operative, which is our aim here to look for that. We in one of the techniques we use diet and exercise, but as I mentioned, most of the patients, they cannot tolerate the diet and exercise. We cannot blame them, but we know that the hunger pain is very portable power to encourage them to eat. So exercise and that enough is not alone is not enough for them. So we have to add augment with them some of medication, which is liraglutide. The outcome would be far more better if we add liraglutide to them. It will give them more comfortable, and they will tolerate the exercise and diet. So again, this is from previous presentation of my colleague, and our finding and studies, we agree that preoperative weight loss will improve the surgical outcome, and it's one of the recommendations for ERAS system if you like to implement ERAS. So it is so many evidence to prove that. If we think about weight regain after bariatric surgery, my colleagues before me, they present many papers and many studies about how many weight regain post-surgery and the technique. It is clear, I don't want to mention too much about weight bariatric surgery associated with regain and with loss. So as you said, sleep, Roux-en-Y, even biliopancreatic diversion, you may have after so many years weight regain. If we take the etiology, I will not talk too much about the etiology because before my colleague, he mentioned the etiology and the technique and the clinical pathway of management of the weight regain. But here we have to think about something. Surgery is not always a first option. If you see this study and many studies, and most of you know that higher complication rate slightly increased with revisional surgery. As you know, as a surgeon, revisional surgery, not la virgin primary
Khalid,
surgery.
1 minute.
1 minute. So this is our revisional surgery. It's not easy. So postoperative pharmacotherapy also it can be used as a first line of management of weight regain after all the investigation because of the surgery. Secondary surgery is not free of complication. Into IFSO 2007, they recommended pharmacotherapy as adjuvant therapy for in bariatric surgery. Also in EASO, also European Association, they recommended as pharmacotherapy as adjuvant therapy in bariatric surgery for preoperative and postoperative weight regain. In our SASMBS guidelines, unfortunately, available, but we have the 21. Most of our colleagues, they don't know about it, but it is there. In our SASMBS, we have our recommendation or to use liraglutide against agonist can be used in the management of class 1 and class 2 obesity, and also effective in downgrading morbid obesity in this patient, and also effective and can be used in weight regain post-bariatric surgery. So in summary, conclusion, bariatric surgery is a potent means of anti-obesity treatment. Weight regain is insufficient or insufficient weight loss after bariatric surgery are known, and treatment with liraglutide weight revisiting can further significantly reduce body weight. Treatment with liraglutide prior to surgery may be utilized for weight reduction in severely obese patients, reduces the hospital stay, and it is more effective than intragastric balloon. So taking liraglutide seems to be an important adjunct to bariatric surgery capable of improving the treatment. Thank you very much. This is our last meeting, 2011. Our colleagues, you can see most of the people there and still practicing bariatric surgery here. Bobby and Scopinaro and other colleagues from Europe attending that meeting 2011. Thank you very much.
Thank you, Dr. Khalid, very much for this excellent lecture. We'll keep all the discussion and question at the end of the session. And now my honor to call for Dr. Haidar Al-Shurafa. He's a consultant of laparoscopic and bariatric surgery, also as well as his hepatobiliary and transplanted surgeon. Dr. Haidar started his bariatric surgery in Prince Sultan Medical Military City in Riyadh since end of 90s, and one of the first pioneer in bariatric surgery. He contributed with more than 36 of publication, and we are honored to have Dr. Haidar in his presentation of revisional laparoscopic sleeve gastrectomy to treat the complication of bariatric surgery. Dr. Haidar, please.
Assalamu alaikum jami'an. I would like to thank the organizing committee to give me this chance to share with you my short presentation, which is revisional sleeve gastrectomy as a treatment for complication of bariatric surgery. Revisional surgery is a moral obligation to the surgeon. And not only the revisional became high in percentage, but unfortunately it is increasing. While the main indications is related to weight loss and weight regain or inadequate weight loss, still the other complications are important and sometimes patient request. Almost all bariatric surgery can be revised to sleeve gastrectomy, but in our practice probably is the most common is the adjustable gastric band. Still there are a lot of limitations for this bariatric surgery as a revisional, but the higher they are higherly challenging, and they specifically need to be sure that the procedure failure, not the patient failure, plus to realize realize the actual expectation and to explain it to the patient. The steps are start from preparation of the patient till the follow-up, and the follow-up should be of long follow-up in this patient in order to do a lot of modulation in their life. Of course, the essential pre-op workup are from, we should include every step which can help us to evaluate and to know more and more about the actual situation of the patient, including blood imaging, endoscopy, and psychology. And also the operative step is the same, but probably they are more and more diverse, and they are variable between each procedure, but we still have to go for each case specifically. The position usually is probably the same, but the surgeon position probably will be variable. The board can be variable in numbers and in the position. The exposure should be included a lot of things, including the crucial assessment and to get the final decision to proceed for the operation. The reversal of primary operation, whether it is band removal or a reversal of the VBG, this is depend on the evaluation intraoperatively, whether to start with reversal or to start with the sleeve. But the further step is almost the same. We sleeve the stomach over 34 French, and we have to check for the vascularity of our pouch and whether there is a blind pouch as in the revision of Roux-en-Y or mini gastric bypass. Leak test. These also can be much more demanding, including methylene blue. We should do it darker, more in volume, higher pressure. Probably we can do gas bubble test because they are more sensitive, but we don't know, is this mandatory or it is optional, but we have done it in all cases. But in the conclusion, the most important thing which we have to do it is we have to check for hemostasis and for leak. Then after that, the post-operative should be a long follow-up, but it is with more conservative steps and slowly the progression. In our experience, that around 6.1% of our sleeve are revisional sleeve, and the average BMI was 46. And here is to show you that how we have most of our cases are both adjustable gastric band, whether either in the same or as a stage. And there are 10% as a re-sleeve. And of course, many of these bypass was related to hypoglycemia. And here, just to show you 3-year post-sleeve gastrectomy, how does the pouch, and if you see how big is the resected stomach, and that is what we have mentioned that could be deserving re-sleeve if that pouch is still there in the patient. And this patient was VBG 6 years with inadequate weight loss. In this schedule, I show that how much is the reason of weight regain, inadequate weight loss is the majority of our case in revisional sleeve, but in resistant, uncontrolled medically hypoglycemia post bypass are another cause for the revision of the sleeve. And here I would like to show you how does it look in the graph, and that is clear. The weight regain is the most important cause for re-sleeve. Unfortunately, these cases carry higher risk of complication, including leak and stricture and bleeding and the other. But the most important, there are many cases also will need further bariatric operation. Of course, these patients will have longer operative time and longer hospital stay. This is just to tell you two things. Number one, it can and overproductive, that is reducing excess body weight, but we have a problem in compliance of our patient. And just to tell you, the most common revisional sleep was after gastric banding, and the revisional sleep can be done for almost all bariatric surgery, but don't forget these are longer time operation with variable outcome and need further study. Thank you very much.
Thank you, Dr. Haider, for this hot topic. I believe there will be a lot of discussion after we finish the session. Stay with us, Dr. Haider.
Shukran.
Bismillah ar-Rahman ar-Rahim. We go to last presentation in this session. Our topic is revision of single anastomosis gastric bypass to normal anatomy. As introduction, we know that this is a wrong mistake of mini gastric bypass. It's a single anastomosis gastric bypass has been an effective like any other bariatric procedure and considered now one of the sole procedure in bariatric surgery. Nevertheless, the severe and several post-operative complications can occur after bariatric surgery, including nutrient deficiencies with deleterious effect of patient health. We know that in patients with severe and refractory malnutrition syndrome, reversal to normal anatomy is a possible treatment option when all nutritional support, oral or TPN, have been attempted and with multidisciplinary effect by psychological and behavioral therapy and concentrating with the compliance of the patient. So revision to normal anatomy is a possible option always in single anastomosis gastric bypass. While several studies have been evaluated, the outcome of the Roux-en-Y gastric bypass reversal due to malnutrition, among other complications, only a few data and publication till now are available in the technique and the outcome of the reversal of mini gastric or single anastomosis gastric bypass to the normal anatomy. Our patient that we revised is 5, and we did in our history that the previous primary surgery, what we did from 2005 till 13 was the Roux-en-Y gastric bypass. Then we shifted to single anastomosis gastric bypass over the last 7 years, where 5 cases converted to normal anatomy, and this equal to 0.7%. 3 cases of these which been had the revision due to severe and refractory malnutrition syndrome, and 2 cases no, actually due to very low BMI of 19, but there is a very strong social reason and depression associated with mild diarrhea. And we will concentrate in these 5 cases. The first case, there was an hypoproteinemia, albuminuria, peripheral neuropathy with general weakness, and she came to us 2 years after the first single anastomosis bypass, and she came in a wheelchair. And her surgery was uneventful. There is a little small video where we can find that the gastric pouch was short, and this is maybe cause a biliary reflux for the patient anteriorating, and she get into depression and stopped medication. The second case, there was due to hypoglycemia, persistent hypoglycemia with all endocrine support and like glucose, and there was a proteinuria, albuminuria, and effect and GPR of kidney. And her surgery was 1 year after conversion from band removal to single anastomosis gastric bypass. Then after 1 year, we convert her reversal to the normal anatomy. There was mild bleeding, which being treated conservative with blood transfusion. The third and fourth cases was only low BMI, and it's not, there was a pressure of social reason. One of the patients by her husband married on her, and the second also associated with mild diarrhea was uneventful, except one of them had developed gastroparesis and been managed with NG tube for 3 days and with medication and resolved. The 5 cases, the fifth case was interesting because patient deteriorate fastly after 4 months after single anastomosis gastric bypass to have hypoalbuminemia and hypoproteinemia, and she stopped everything, and later on she been affected till it reached to liver failure 8 months after the procedure and get into encephalopathy. The patient transferred to liver transplant center and hepatic unit where they manage her over 2 months until liver enzymes return to the normal and patient better and become in better condition. So they refer her back to us, and we put her 5 days in complete enteral feed with completing all the multivitamins and thiamine, and prepare her more for the surgery. And her surgery passed uneventful. And when we review the publication, most of the cases after Roux-en-Y gastric bypass or single anastomosis bypass or peripancreatic diversion who went to a liver failure being treated by a liver transplant. This patient is treated by revision to normal anatomy and saved from a liver transplant, and it's been published as a case report. You can see the texture and the color of the liver is it's changed and fibrotic. Wasn't this the liver in the previous surgery? So we have to dissect either by sharp or blunt dissection or to separate the gastric pouch from above the line of the gastrojejunal anastomosis. We use the purple of tristabular or any devices. So we create a gastrostomy, simple gastrostomy opening tube in the remnant stomach and in the gastric pouch, and we do side-to-side anastomosis. But here, actually, we have to use 2 loads. The first load, then we introduce second load till we reach to complete opening the gastric pouch to the remnant stomach, and we do our anastomosis closure of the gastrostomy opening in a double layer, a continuous with a 2O vicryl, then interrupted with the 2O silk. After that, we tested with high pressure of methylene blue, and we put NG tube to deflate the stomach, and we put a drain after. This is another case, but because of shortage of time, but to show this is the first case where the gastric pouch was short, and the reason I believe in the patient developed biliary reflux. So because of short of time, it's only 5 minutes of presentation. I'm going to conclusion. This is our publication in International Journal for the case of the liver failure after 1 anastomosis gastric bypass when revived to normal anatomy. And as I said, most of the review for the presentation was it's been reversed to, it's been treated by liver transplant. This is a case which is being saved by the revision. In conclusion, revision of single anastomosis gastric bypass to normal anatomy is visible and should be done in Center of Excellence for Bariatric Surgery. Severe and refractory malnutrition syndrome following single anastomosis gastric bypass is rare. In our study, 0.7%, and severe condition when refractory treatment. Also, it's a burden by weight regain. The revision of single anastomosis gastric bypass permit a resolution of malnutrition syndrome in most of the patients. Early detection of impairment and early intervention by revision to a normal anatomy can be experienced by a surgeon as considered to be safest and most effective procedure for liver failure post-bariatric surgery. Thank you very much. Now I will share the session with my colleague, the panelist, Dr. And we have to see our question. There is 4 questions.
Ahmed?
Yes, sir.
May I comment until you find
Yes.
the question?
Yes.
Yeah, to all my colleagues here, I would just comment, like to comment about gastric bypass or single anastomosis gastric
Single anastomosis, yes.
Anastomosis gastric or one anastomosis gastric bypass. Please,
is not.
Please, it is we have a very nice standardization technique. The pouch should be 50 to 18 centimeter long, and the biliary limb, please don't go more than.
The sound is not clear, yeah. Khalid, Dr. Khalid.
Okay, now it's okay. Regarding the pouch, size should be 15 to 18 centimeter long and 3 to 4 centimeter width. The size of the pouch. Regarding the biliary limb for metabolic surgery for diabetic, it should be 150 centimeter. Regarding obesity, please don't go beyond 200 in Saudi Arabia patient, even this patient more than 50 BMI. Below 50, please go, you have the choice from 170 to 180. Please
silent.
Be careful about the. You can hear me now or still not good?
No. Yeah, Khalid, you need to bring the mic close to your mouth. Mic.
Okay, now it's okay.
أيوة.
Yes.
We have.
I will just summarize our standardization of single anastomosis gastric bypass, which was the summit for that. As I said, 15 to 18 centimeter long. You use maximum 4 transverse size of transection, and the length 18 to 15 centimeter long. Please, the biliary limb. This is a very important thing. Biliary limb for metabolic surgery for diabetic, 150 centimeter, and please don't go before more than 200. Even the BMI more than 50. Don't go more than 200. Regarding the measurement of the bowel, it is optional, but if you don't go more than 200, you don't have to measure it. You have to go 160, 170, 180, 190 maximum, but don't go beyond 200. All the metabolic complication, what's happening, just Dr. Al-Garzai mentioned, it is due to size of the biliary limb. That means excessive malabsorption, which lead to excess weight loss, excess protein malnutrition. Regarding the revision, if you have a complication, we don't have to revise it to normal. We don't have to revise it to normal. You can reverse it, shortening the limb or convert it to gastric bypass, so you will not lose the power of weight loss. This patient will come to you after 2 years with again BMI 40, 45. They will ask for another surgery. So we have to think what procedure. Thank you.
Thank you, Dr. Khalid. We have, I think we have to share the questions from the poll, and if we can see it from Ms. Sarah or Dr. Al-Ahmadi, the questions. Okay. I have this question is when is the ideal time to reverse single anastomosis gastric bypass to normal anatomy? Multiple choices in early sign or in non-compliant patient in moderate to severe depression for social reason. If I can have a comment from Dr. Our panelist, Dr. Haytham Al-Falah and Dr. Ali Maneh.
Yeah,
what do you think, Dr. Haytham?
I will. Revision to normal anatomy, it is one of the choice to revise that type of surgery. But as Dr. Khalid said, there is many other choices to do it. Going to normal anatomy, it is one step. I think later on, it will correct the situation, the complication which happened, which necessitate this type of surgery. But later on, or in the same setting, you can convert it to more to other type of surgery. So just restore the normal anatomy. It will help in the one step of the solving the problem.
Excellent. Ali Maneh, Dr. Ali, Dr. Abdurrahman Al-Saigh. Dr. Abdurrahman.
Hi, Assalamu
alaikum.
I think revision, once this, you mentioned, Dr. Ahmad, all the 5 cases, I think there is no question about revision. This is mandatory because this is now common affecting the patient. So I think to restore it to normal anatomy, then think about the other procedure is very important because now it's critical. It may affect the life of the patient. One of your cases, in 4 cases, you catch the patient before they reach the liver failure, which is the worst scenario you have. So I think it's better to reverse the anatomy, then think about the weight regain and weight loss in the patient.
Okay, so it is 47% in early signs of malnutrition and vitamin deficiencies in non-compliant patients. We'll go for the second poll question. So the question is, the patient regain weight to morbid obesity and asked to redo surgery. What is the ideal procedure? Restrictive procedure as a sleeve, Roux-en-Y gastric bypass with a short peripancreatic limb and long common limb, pharmacotherapy or other you can suggest. If we can have the opinion, again, Dr. Abdurrahman Al-Saigh.
I think in this scenario, I go for gastric bypass because you already give the chance for restrictive procedure. So the ideal probably, if the patient of condition is allowed to go for another surgery, I think I will go for a gastric bypass. So the patient can get benefit from bariatric surgery. A combination of pharmacological therapy, I think if it's the patient regain just a small small amount of kg, like increasing like 2 BMI or 3 BMI, probably you can consider pharmacotherapy surgery. Otherwise, I'll go for gastric bypass.
Dr. Mahmoud Sadegh. Dr. Mahmoud. Dr. Mohammed Al-Aqil.
Yeah, I would like to go for other, trial of diet and pharmacotherapies. So we will give 3 to 6 months for that. So if it's not so, I will go definitely with the Roux-en-Y gastric bypass with the short maybe.
The scenario is maybe
after
like
sleep.
that she come back to you after 2 years, 3 years healthy, but regain to morbid obesity.
But I
And,
have to go for, I have to go for a trial of diet and pharmacotherapy. So if it's not help for the patient for 3-6 months, so I would like to go for.
What is the length of the limbs, peripancreatic, elementary, and common limb in the NY bypass, if you will do?
So I would like to go for 100, maybe 100. Yeah.
And Dr. Haytham?
Yeah, let us go for more individualized solution for the patient. This is not standardized for all the patient. Each patient needs to be evaluated individually, and we'll design the best solution for him. So going for more conservative after failure of surgery for that thing, I don't think it will add extra step for the patient. We need to find for him the reason for regaining weight for this patient and design the solution for that things.
In Dr. Haider Ashraf presentation, he converted mini gastric bypass to sleeve gastrectomy. May I hear your opinion, Dr. Haider?
السلام عليكم again. شكرا للسؤال. I think I will think more about each case individually, but if you go to the literature, of course, the best salvage operation will be raw NY gastric bypass, regardless of the measurement, what measurement we decide to use. But usually, those who have regained weight, they are more resistant to lose weight. So in these cases, probably we have to be more aggressive in treating the weight regain in such a patient. This is from the question point of view. From your question point of view, in our cases, the mini bypass and they were all of them, they are medically uncontrolled hypoglycemia. So the reason is to continue have weight loss as well as to control the hypoglycemia in such patients. That is why it was converted to sleep.
Thank you, Dr. Haider. We'll go for the third poll before third question. How frequent can a revision to laparoscopic sleeve gastrectomy to be trusted option after failed or complicated adjustable gastric banding? Never advise liver sleeve gastrectomy. Should always be the first choice. Can be done in a selected patient. I have not done. This is a common question. Always we face it in the clinic. Patient comes with banding, gastric band. So,
Ahmed, can I comment?
Yes, sir.
I think I'll go for the second choice, which is options, which is sleeve gastrectomy. Also, I think we'll give the patient a chance of sleeve gastrectomy. Always, although it is a restrictive procedure, but also have some. It's not like a gastric banding, mainly restrictive. It says have some hormonal changes.
So it is your always the first choice.
Yeah.
Before.
Yeah, so I'll give the patient a chance before I go for, gastric bypass.
Yeah, in 2007, 2008, we in the maybe Khalid Mirza can correct me. The Congress that he did at that time in 2008, the first one in Eastern Province, we've been in discussion with our colleague from King Faisal Specialist Hospital who started first, and Hammouf and others from Jeddah. At that time, conversion from band to sleeve reaching the complication more than 15%. Now, with the literature, the leakage complication reduced dramatically, but it is not less than 3%. You still can tolerate 3% complication of leakage after conversion from band to sleeve. This is high percentage to me. Any colleague can contribute.
Yes, Dr. Ahmed, 3%, it is just the double of the normal leakage post primary sleeve gastrectomy. It is the double percentage. So in revisional surgery, you can accept the double percentage of complication for that things.
So is it selected cases or first choice to you?
And no, it is for sure. It is selected cases for that thing. You need to evaluate why you need to remove the band and what is the best choice after that band removal. Is it a failure of the band? If there is any complication happened with the band, necessitate removal of that band and looking for the next step for that things.
I think the history is very important, Dr. Ahmed, here. If the patient is sweet eater, probably you consider something else. So I think we need to get more details on the patient, why she regained weight, as Dr. Haitham said.
The last question, I think, are we finished? I think there is one question. How would you,
Well, Ahmed,
comes from the, yes, sir.
Thank you so much, Ahmed. If you can conclude the session just to start that, I really appreciate it.
Thank you very much. Well, yeah, I think we are behind of time. Thank you for everybody, our colleague, the speakers and the panelists and the audience. And we thank Dr. Aid for the organization. Thank you very much.
Thank you.
Thank you very much.
شكرا لكم جميعا. Now we will go on, and it's a pleasure to call on Dr. Abdurrahman Al-Salam for the next session. We apologize for being late, but we will have, I'm sure, very interesting videos for the team. And we will go, Abdurrahman, I think you already on, if you can, yes. Abdurrahman, please. Abdurrahman is very well-known senior bariatric surgeon. He's one from the pioneers who started also in King Faisal and then to private. So please, Abdurrahman.
Bismillah ar-Rahman ar-Rahim. Prof. Aid and the colleagues, I appreciate your invitations. It's a bit too late. It's almost midnight. We'll try to go as fast as we can. I'd like just to introduce our panelists, Dr. Atif Bassas and Dr. Basma Fallata, Dr. Fawaz Al-Rashid from Hail, Prof. Omar Al-Abeid, and Prof. Naif Al-Ainazi. The first speaker is Dr. Assam Bataya. Assam is around, huh? Assam, you will present a case of splenic abscess after sleeve gastrectomy. I'm sure that everyone know Assam well. He did an excellent job yesterday, and I'm sure he will do another excellent job today and tomorrow as well. Assam, would you like to go ahead and present your case, please?
Thank you, Dr. Abdurrahman. It's a great pleasure and honor to be with you today, and I will try to make it as short as possible. So I'm presenting a spleen abscess after laparoscopic sleeve gastrectomy as a rare complication, and thanks to my resident, Dr. Awad Yassin and Dr. Faris Al-Sharif, who helped me to get this together. As an introduction, laparoscopic sleeve is a standalone bariatric procedure that it reports many procedure complication, but to the formation of splenic abscess is very extremely rare. Our case presentation, she is a 22-year-old female with a BMI of 41 and weighing 115 kilogram, underwent an eventful laparoscopic sleeve gastrectomy. She went home smoothly almost the second day. 1 month later, She presented to the emergency department with an abdominal pain, vomiting, and intolerance to oral intake. Her labs almost was within normal, and her CT revealed that collection about 2 by 2 with a small bucket of air. So it was highly suspicious, and you can see here from the CT scan, all workup was done as usual, but we failed to find exactly the leak, and this is the almost scenario that we always get. So she was treated as a leak, but conservative management, and she responded very well for TBN over 4 weeks, and her condition improved. Patient went home 1 year later. She presented to the emergency department having fever and abdominal pain. Her labs just returned back with normal except a mild leukocytosis. So the CT scan, it was showing, as you can see in the pictures, there is a splenic abscess. So she was treated at that time with an IV antibiotic because we failed to see that any connection between that and the sleeve that she did. Even the gastrography, and you can see on the right side, it's showing a normal perfect sleeve and the contrast passing easily. And there was no extravasation of that. 3 months later, she presented back, and again, all workup was done and repeated again, and it's failed to negative regard any fistula tract. And there was an area of suspicion that raised my high index of suspicion that there is something going on. Otherwise, the patient should not have this recurrent. So my final decision was to take the patient to OR. So we took the patient for surgery, and we start the procedure. We start to do the dissection, and I try to go all over the lateral aspect of my previous sleeve, doing some meticulous dissection, going all over, trying to delineate where is the connection that it being exist actually between the spleen and the residual part of the sleeve, the stomach. So try as much as possible to delineate where is this fistula tract that I assume it's the main reason behind this recurrent splenic abscess. So going all over, trying to delineate, I just only find this one connection area, which is at the upper part. And we pass all over and reaching all the way up to the gastroesophageal junction and delineating all
the video is not clear, Hassan. The video, if you can share your video.
Sorry. Okay. Now the video is clear?
Yeah, now it's working.
Okay. So I start the dissection as I just mentioned earlier, and trying to reach all over to the area, to the gastroesophageal junction, doing some meticulous dissection, try to identify where is that fistula tract, and reaching all the way up. So after finishing with that, I start to tackle the area here of the spleen and going all around and try to reach almost identifying where is exactly the area of that fistula. And just only we find only one track at that time, trying to identify it. Then we pass the bougie, and I try to use even the methylene blue so that at least to stain that fistula tract. So before doing any cutting to it or something that it will be there, then I try to tackle the spleen area and to free the area so to have a clear identification of it. Then we poke the bucket of the abscess, as you can see, and we start to do complete mobilization and aspiration of that bucket abscess. And I go from lateral to medial, trying to clarify and taking down all of this adhesion to the anterior abdominal wall. Then try to dissecting little bit the lower pool and identifying the pedicle, separating it from the colon, reaching all the way up until to the diaphragm to mobilize it from the diaphragm up, using little bit of sharp, little bit of blunt, some using with the, until we finally reach and completely mobilizing the whole spleen all over and making it just only hanging with the small tag at the upper part. So reaching to there, I back again to my fistula track and identifying that fistula track. And I did a double clipping on that. So this is the fistula track that I could identify. And I just did a double clipping for both sides and then cutting it off. So back again to the presentation. So the patient on the third day post-operative, the drain was showing some gastric content. So we did an upper GI endoscopy again, and we find again the pinpoint that's on the endoscopy. So we did with the clipping. And she was placed in BO and TPN for another 2 weeks. Finally, she was discharged with full recovery. She was fully followed up after 1 month and 6 months. She's doing very well and her condition stable. Reviewing the literature, there is a nice systemic review which was done by Dr. Nasser Sakran and his colleagues, and it's revealed that around 18 patients who had the same scenario almost. 11 of them were female, 7 were male. The mean age was 34. Fever was the most common presentation. The mean duration, it was variable, and sometimes it's reaching up to 132 days. The 7 patient has reported leak, but the rest were due to bleeding and some others. And most of the patient, 13 patient had a unilocular abscess. All patients were treated with antibiotics, and most of the patients, 11 of them were needed and underwent splenectomy as our patient. This is another review or a table for the cases with the age and if they were on any some immunosuppressor and the treatment and also the culture for their antibiotics. Conclusion, the splenic abscess following sleeve gastrectomy is a rare identity. The etiology formation of that, it's sometimes need further study, further workup. CT scan is crucial and it's the preferred diagnostic tool. And still there is no gold standard apart from sometimes it's end up with the splenic abscess as we did. Thank you.
Thank you very much. Well done, Sam. And it's very rare, and have one case actually you ended by splenectomy. We'll keep the discussion at the end if we have time. We'll proceed with Hussam. Hussam is the director of Pediatric Center in Arm Hospital in Tabuk, and he was going to present to us what may go wrong in many gastric bypass. Hussam, if you can present your case, please.
Thank you very much. I'm just going to share my presentation. Is it clear now?
Yes.
Okay. Actually, it is. I'm going to try to be very fast because of shortage of time. This is a case of 33-year-old female lady who was complaining from low back pain, secondary infertility, hypothyroidism, and thyroxine, and she had history of cesarean section. Her body mass index was about 41. She did all investigations pre-operatively, including endoscopy, which was normal, or her labs were normal. And patient was booked actually for one anastomosis gastric bypass. The case started with by my fellow, but what happened actually can happen with any surgeon. So it's good to learn from this one. We will start with procedure by creating our first stapler in the horizontal area of the lesser curvature of the stomach. We usually do long gastric pouch, starting with the cartilage. Then actually it was very straightforward procedure. I'm just trying to concentrate of what happened here, opening the angle of His. Final cut of the stapler. We open the stomach. After check, you can see the calibration tube, usually 36 French. Before any creation of the gastric pouch, I usually identify my limbs to be sure that it is no adhesions and can be reached safely. Here, belly limb was 150 centimeter, and we start to do the anastomosis by stapler. You can see here trying to create the gastrogenostomy. As I said, this case was stated by my fellow. There was some difficulty to put this stapler, but finally he managed to create the anastomosis 4 centimeter. We're checking the posterior to have 1 centimeter between stapler by 2 stapler lines, so will not have any ischemic area. And the anastomosis was fired. At this point, actually, I was not happy by the anastomosis. You can see, we can find here fat pad in the between the stomach and the jejunum, which should not be there. As again, my fellow was in a hurry to close the gastrostomy. I asked him to stop. If you can look here, it's now very clear. This fat pad here. Indeed, the anastomosis actually but was between the jejunum and the posterior fat pad of the stomach, not the enterotomy which was done initially. You can see here, this is the initial one. So here we had to dismantle the whole anastomosis again and to create a new one. Complete dismantling using harmonic and scissor. Of course, we'll find some bleeders who can be easily stopped. Here you have many options actually to create your anastomosis. I elected to do one more first. This the technique should be actually done to prevent such kind of complications. And we did proper gastrogenostomy. Here you can see very clearly two mucosa. And you can close this long enterotomy either manually or using stapler. We elected to use stapler and to close this defect tangentially, as we can see now. Here you have to be very careful not to jeopardize the lumen of the jejunum. And just for, and this is the end of this tragedy. Postoperatively, it was an uneventful course. Patient was discharged day 2. Usually discharged first day, but with this patient we kept her 1 day extra. Patient was seen 1 year postoperatively, and her body mass index dropped from 41 to 26. And thank you very much. I hope I was not late. Thank you.
Thank you very much, Sam. Any further comment?
Oh, thank you.
All right. Nice catch, actually. And it's very good that you would been able to catch it interoperatively. We'll proceed with our presentation. Next case will be Prof. Al-Nami. Is Prof. Nami around?
Yes, I'm around.
كيف حالك بروف؟
حياك الله، هلا وسهلا.
معلش مسهرينك احنا الليله.
ماشي، اليوم جمعه ما في ورانا شيء.
طيب. Prof. Nami, and he's one of our senior colleagues in King Saud and Prince Sultan Martinelli City. He will present a case or video around redo gastric bypass options and outcome. Prof, please.
Okay, thank you. Thank you very much. I'll just go ahead and share the screen. So can you see my screen? Can you see my screen?
Yes, sure.
Good.
You can put full screen.
Yes, we can see it.
Okay. So redo gastric bypass options and outcomes has been extensively discussed tonight by Prof. Filshauer and Prof. Bruno Delemans, and they paved the way for me not to go further on options, etc., and outcomes. They saved me the time. Thank you very much. However, I may complement their presentations by a video to demonstrate the revision or redo gastric bypass. I have no disclosures. If I may start with the case scenario. MA is a 36-year-old male living with obesity. He's a status of post-laparoscopic Roux-en-Y gastric bypass done by myself in 2011. His weight from that time has decreased from 168 to 60 kilograms. His BMI was high at that time as well. That's why we opted to do laparoscopic Roux-en-Y gastric bypass, not a sleeve. And even at that time, if I knew that his weight is that much, I could have done also SADI, but we were not up to the time of SADI at that time. On 2018, he started to regain weight after he sustained multiple injuries from a road traffic accident with prolonged hospitalization and rehabilitation, unfortunately. So since 2011, he was fine, having good weight. And I was surprised when I saw him in 2020 with his current weight at that time, 2020, August, of 147 kilograms, his height 154, and his BMI 62. I really referred him for a multidisciplinary team in Prince Sultan Humanitarian City, where they have a system and found that he needs revisional surgery. He has good behavior, but the accident really made him regain weight and multiple injuries. Barium meal, as you can see, showed a slightly dilated gastric pouch with a little bit of wide stoma. This is the esophagus, this is the G junction, this is the stomach, and this is the stoma with a little bit dilated candy cane loop, as maybe a behavior of the patient eating large portions of food. So now, if I pose this question, in this case of weight regain after gastric bypass, what's your best option that may give the patient the best outcome? Please ponder for a while, reading the choices here, and we're gonna go over them later on and see what is the best. We took him for OR in August 2020. The roux or enteric limb was 200. The biliopancreatic limb was 100 centimeter. The common channel was 500. So after revision, we have resized the gastric pouch over a 36 French calibration tube and the stoma, of course. The roux limb was left at 200 centimeter. The biliopancreatic limb was distalized to 200 centimeter. And the common channel limb remained at actually shortened to 400 centimeter. If I may share the video. So this is the gastric pouch and the anastomosis complex. As you can see, it is dilated, and the stomach is also a bit dilated. And really, I went for this step because the patient claims that he eats large portions of food. So I assume with the barium study that he has a big gastro-jejunal complex, including the candy cane that you can see here. So we dissected that pouch, and you can see here is the gastro-jejunal anastomosis. And this is part of the candy cane loop, and this part is part of the stomach. We resized it over a 36 French calibration tube, as you can see.
Video is not working, Prof.
They are small after resizing of the gastric pouch. Then we did methylene blue testing on the spot, and it looks fine. No. Then we went to the jejunostomy anastomosis. You can see the common channel here, and this is the roux or enteric limb. And this is the blind loop. We need to dissect it so we can do proper distalization of the biliary limb by cutting the insertion of the roux limb.
Video is not working. Off.
This is the roux limb, and this is video is not clear.
It's not. It's and that's okay. Carry on.
Okay, can you see my cursor?
Yeah, we can see it, but there are like hold up and then goes again.
Okay, sorry. So I am dividing. I divided the roux limb at its insertion to the jejunostomy, and you can see the end. And then we started to distalize the biliary limb. Okay. Of course, it's the common channel now, but now it's becoming the biliary. we make, I just fast forward the space futures here.
Not gone. Yeah.
So tell me, and fast forward. Then I close the stoma manually. Sometimes I close them with the stapler, but in this case I put manually to avoid any narrowing of the jejunostomy. I use 2 layers here in redo because the bowel is fit and healthy from previous dissections and current dissections. Okay, I close the jejunostomy defect again. The Peterson space as well. I put it in and lymph out. So that's my session. Thank you very much.
MashaAllah. You have a follow-up on the weight loss, Prof?
Yes, this patient came to me on the first visit, losing 10 kilograms, of course, because he's on liquid diet. And then he disappeared, and I found him in United States doing master's degree, but we could not get hold of him since 10 months, really. And I hope he will make touch with us and will update you on his case personally, inshallah. Thank you.
Is he compliant with his supplements?
Oh, yeah, he is. He's the reason I did surgery for him. I found him very enthusiastic to go over his accident outcomes and injuries, and he wants to pursue further studies outside and get married, etc. So we try to help him, but we warned him that he should abide by the follow-up and the supplements, etc.
And I'm sure that you have done the right job. I hope that you will stick to the principle of continued follow-up and supplementation. That's the main issue here. All right, thank you very much, Prof. We'll move after that to Dr. Abdul Sharafa. He's our senior colleague from Military Hospital. Dr. Sharafa, are you around?
I am around, sleepy.
معلش احنا ده البرايز بتاع التكنولوجي يعني ف we have to pay for it.
موفقين مع الشكر الجزيل للجميع يعني.
يعني it's so far it's been excellent meeting ف bear with the technology. Prof Haider, انت you will talk to present to us a revisional Roux bypass after VBG, restrictive to malabsorptive.
Inshallah. Thank you everybody to share with you this laparoscopic revisional bypass after vertical banding gastroplasty in a woman of 49 years.
We are not seeing your slides. Can you share your slides? Share your screen.
أنا لحظة بس. يفترض انها sharing screen. انا عندي هنا.
I don't see it. Yes, you can you go to the first slide, or that's the first slide?
This is the slide. Okay, is it okay?
Yeah, it's okay now. We can see 49 years old female status post VBG before 16 years.
This patient is complaining of weight regain and GERD symptoms and sign with type 2 or diabetes mellitus on oral hypoglycemia, and current current BMI is 46 BMI. Where we work her thoroughly, we start the operation by adhesolysis in order to explore the gastric pouch and as well as the native gastric stomach. And as you see here, we go with the adhesolysis up to the hiatus in order to have a full view. Then we go to the laser sacs from the middle side and above the mesh side in order to get virgin area as well as that will to resize this stomach pouch. Here we do the devascularization of the fundus and continuing the adhesolysis up to the left crura. The transverse stabling started really above the mesh and transversely, and then tubular over 34 French tube. And that stabling will be continue with excision of the fundus, and that will ended with resection of the fundus as well as the dilated part of the pouch. Then we do applicate or invaginate all the stabler line. After we test the stabler line by gas bubble test, we create gastrostomy. Then we count 50 centimeters from the DJ junction in order to bring the raw limb up. And we do the anastomosis using a white stabler and usually between 25 to 30 millimeter in size, and using the linear stabler. Then we close the stoma using the BDS 3.0, and usually we do it in 2 layers. First layer full thickness, and the second layer we usually with number, and that will be in full second layer. Then we create the jejunostomy in the biliary limb. We count now 150 centimeters from the gastrojejuno anastomosis to create the foot anastomosis, which is the jejunal anastomosis. And again, we use white stabler of full thickness, full length, I mean, of 60 millimeter white stabler. Then again, we close the stoma using the BDS, and usually again, it is in 2 layer continuous. First layer is full thickness, and the second layer also in the Lambert fashion in order to invaginate the edges. And once we finish with the closure, we divided the limb in order to conclude the bypass. And of course, that will be also actually all the small bowel anastomosis and division, we use white stabler. Then we close the mesenteric defect using the 3.0 silk, and usually in continuous metal. And finally, what we do is to close the Peterson defect again with the silk and 3.0 silk. After we conclude that, we usually again do the methylene blue test, and the patient has uneventful post-operative course and discharge in second post-operative day. And then we saw her after 2 years where her BMI were 28 and resolved GERD and free of diabetes mellitus. Thank you very much.
Thank you very much, Prof. Haider. Well done. I'm sorry for the late timing, but we'll have to proceed. Our next speaker. معلش أنا lost the schedule. It's Dr. Awad Al-Qahtani. Dr. Awad.
Then, hi, assalamu alaikum.
طيب.
So today we'll, how are you, Dr. Abdurrahman?
أيوة بس increase your screen. Yeah, go ahead, please.
Yeah, so today we will present one of our cases, which is revision cases, Scovinaro procedure to single anastomosis bypass. My fellow, Dr. Mohammed Al-Mayouf, will start the case presenting now.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It's an absolute honor and pleasure to present today in this great conference with pronounced speakers and panelists. So as Dr. Awad mentioned, we had a patient in our clinic who underwent Scovinaro's procedure around 15 years ago. He's 28 years old. He had a BMI of 49, and he underwent laparoscopic cystectomy 2 years after. He was complaining of vitamin deficiency, fat malabsorption, picture of partial bowel obstruction and several ER visits because of that. In addition to vitamin deficiency and malnutrition, although he received multiple replacements of vitamins, despite that, symptoms did not improve, and he was getting the symptoms starting to get affecting his quality of life. We worked the patient up by doing imaging, which showed dilated bowel loops and partial bowel obstruction. So the patient was seeking for a solution of his symptoms, and after working up the patient and preparing for OR, we went for the operation. And as you can see in this first video, you can see we evaluated the anatomy. You can see the gastric pouch in this area, and this is the candy limb, or the candy portion of the alimentary limb. The stomach was excluded. And then we proceeded with measuring the alimentary limb, which was around 400 centimeters. We then evaluated the biliary pancreatic limb, which was around 420 centimeters until reaching the DJ junction, as you can see. And then we measured the common channel, which was around 100 centimeters. So based on what we found, it wasn't a classic Scobinaro. It was probably a modified Scobinaro. As we know, the common channel is around 50 and the alimentary limb is around 200, but in what we found in the patient was almost double. So we wanted to achieve two goals. The first one is to relieve the symptoms that the patient was complaining of, and secondly, avoid making the patient gain weight, because he was adamant to keep his weight consistent. So we decided to convert the patient to a mini gastric bypass or a single anastomosis gastric bypass by utilizing the candy, as you can see here. It was well vascularized and easily accessible. We decided not to go for the gastric pouch because the anastomosis was posterior, it was up, and that might jeopardize the stomach pouch. So we measured 150 of the biliary pancreatic limb, and then we did a side-to-side anastomosis with the candy limb. After that, we divided the distal to the anastomosis of the biliary pancreatic limb. We divided the distal to the anastomosis, and that part will be used to connect with the alimentary limb. As you can see here, we trace the alimentary limb to the junction, as you can see here, and will be connected to this limb, which is the newly divided biliary pancreatic. As you can see, going through the mesentery and then dividing the alimentary limb, and then establishing the new anastomosis between the recently divided limbs, thus restoring the continuity of the bowel, side-to-side anastomosis. And all of the anastomoses were sutured in double layer fashion. And Of course, all the mesenteric defects were closed before concluding the procedure. The procedure was sorry. So this is a simplification of what happened. So this is the biliary pancreatic limb, and this is the anastomosis that we did with the elementary limb. And here is the second anastomosis between the elementary limb and the newly divided biliary pancreatic limb. So all of this was became the common channel. Luckily, the patient tolerated the procedure very well. We did contrast study after the operation. It was fine, and the patient was seen in the clinic afterwards. He was happy with the result. He actually lost more weight, and he reached to an more optimal weight. No more ER visit, no more partial bowel obstruction, and all of his symptoms went off, and he's feeling much better.
What was the length of the biliary and the elementary at the end? How did you measure, like what was the biliary and what is the elementary from the stomach down to the common channel? What was the length of the common channel and what's the length of the
before
the green, which is the biliary?
This was 150.
And the
from the DJ, we measured 150, and then we connected to the elementary limb.
Great. And the elementary, the total length, how long it was?
The total elementary was 400, and the common channel was 100.
Oh, it's a common channel now. It's a totally common channel now.
It's now totally common channel.
So the whole, it will be like 5 meters.
Yeah, so we restored the whole bowel, and then we converted the modified Scobinaro into a one anastomosis gastric bypass.
Very good. And his malabsorption being corrected after that.
Yeah, no more frequent bowel movements. He feels much energized, and his quality of life improved very dramatically. And actually, he lost more weight, which made him also happier, reaching to the BMI of 23.
And he did not touch the stomach?
No, we did not touch the stomach, as I mentioned, because it was, we didn't want to jeopardize the stomach by dissecting the elementary limb. And since the candy limb was accessible and well vascularized and easy to establish anastomosis, we elected to use it for the anastomosis, and it went very well.
Very good. Thank you very much.
Thank you so much.
All right, we'll move to the last, but not the least, is Dr. Ahmed Jabbo. He's a senior registrar, I think, at Military Hospital, and he will present a case of CA of the gastroesophageal carcinoma after sleeve gastrectomy. Is Dr. Ahmed around?
Yes.
So if you can share your screen, Dr. Ahmed.
Okay, sure. I'm sorry, how to share the screen?
You will have a green box in your screen.
Okay.
Saying share screen. So just press on it. Excellent. Perfect.
Okay. Thank you, Dr. Abdurrahman. I'm very grateful to participate in this great event. I'm going to present a case of gastroesophageal carcinoma that was discovered, and then after sleeve gastrectomy. And a few years after that, she underwent oncological resection in our institution, Prince Sultan Military Medical City, led by our mentor, Dr. Abdullah Zahrani. We'll start with the clinical data. She's a 58-year-old female, presented initially in another institution with the history of reflux disease and heartburn. Also, she's known to have rheumatoid arthritis, though she didn't receive any steroids. Her initial BMI was 52 before the bariatric surgery. Patient underwent laparoscopic sleeve gastrectomy in 2016. And 1 year after that, she presented in our clinic with persistence of reflux disease and anemia. And at that time, her BMI was 42. So we started with the investigation with upper endoscopy, which shows mild hiatal hernia and mild reflux esophagitis. And there was a positive H. pylori infection on biopsy with no dysplasia or malignancy. And she received the full course of treatment for H. pylori. After that, we planned for her for revisional surgery and repair of hiatal hernia. But due to our long list in our institution, the patient lost her follow-up. So she represent again with history of dysphagia for the last 4 months. And that was in January 22. And so we proceeded with the upper endoscopy, which showed a polypoidal mass at gastroesophageal junction, 5 centimeter from the incisors. So we started our staging after the confirmation of the biopsy, which shows invasive adenocarcinoma. CT, chest, abdomen, pelvis, and PET scan was done. As you see here, there is clear thickness at the cardia and also high uptake at the PET scan. So we took her for diagnostic laparoscopy with peritoneal lavage for staging, which confirms the diagnosis of malignancy after showing atypical cells and mucin in the cytology report. So after the multidisciplinary meeting, we started the patient on neoadjuvant chemotherapy. She took 4 cycles at about 8 weeks. And after that, PET CT scan was repeated, which shows almost complete response. So a few weeks after that, we took the patient for oncological resection. And a few days after that, she was discharged with full recovery. The pathological staging, just to mention, it was T2N1. I mentioned that because in the literature, we will focus on the staging. So we'll go through the literature review, starting by the incidence of gastric cancer. It's over 1 million cases of gastric cancer diagnosed each year worldwide. It's the gastric cancer considered the 5th most commonly diagnosed cancer in the world. The cumulative risk it measured 1.87 in males and 0.79 in females worldwide, with higher incidence in Eastern and Central Asian and also Latin America. The risk factors are multiple, but the most significant is H. pylori infection, which usually lead to chronic inflammation and atrophic gastritis. Also gastroesophageal reflux disease, family history of gastric or gastrointestinal cancer. Smoking is also considered a high risk, gastric polyps, and obesity with high BMI. Any patient going for bariatric surgery should go for obesity screening and preoperative assessment. So we should consider risk factors like we mentioned in the risk factors before, the smoking cessation and decreasing the weight and other risk factors. BMI is also, whenever the BMI is higher, that makes the patient more risk at developing let's say, malignancy in general. Upper endoscopy is a dilemma, and there is still no consensus. So always the question to be asked should upper endoscopy to be done as a routine investigation or not? This is a systematic review about esophagastric cancer after sleeve gastrectomy, included 17 cases with gastroesophageal cancer and esophageal cancer. Only four cases of them were distal esophagus, and 4 cases was at the gastroesophageal junction, and the others in the other part of the stomach. The mean BMI at presentation before the diagnosis of cancer was 46, and at the diagnosis was 36. The preoperative, only 13 patients underwent upper endoscopy for screening, and fortunately, the endoscopy shows only mucosal irritation in half of them, and the others was with no findings. There is no documentation about reflux disease, only with one case. And at conclusion, the authors suggest that upper endoscopy should be done routinely because the bariatric surgery is becoming more popular, and more patients are going for bariatric surgery. So the risk for developing malignancy is higher. There is other study that questioned the upper endoscopy as is it mandatory or not. This study shows a total of 523 patients, with 257 shows no abnormality, and 117 abnormality like only gastritis or irritation that doesn't need any intervention, and 84 with H. pylori that needs eradication and they received treatment. 13.6% shows Barrett's esophagus and reflux disease that needs PPI, and also 6 of these patients needs rescope annually. Only 1 patient from the 523 diagnosed with cancer pre-op, and after that the decision of bariatric surgery deferred, and patient underwent oncological resection. So the conclusion, as you see, that endoscopy should be done only in selective patients, as there is low risk for general people to develop gastric cancer. There is also another study about endoscopy in adolescent before sleeve gastrectomy. There was 94 patients who underwent endoscopy. 46 had abnormal findings. Like the other studies, gastritis, also fundic polyps, and irritation and mucosal enlargement. Interestingly, there was a similar demographic characteristics for both groups. At the end, the author conclusion was that symptoms were the only predictor for gastric upper endoscopy abnormality, and abnormal upper endoscopy findings were not associated with modification of surgery or any adverse outcomes. So at the end, we conclude that usually endoscopy, there is no clear consensus about upper endoscopy before bariatric surgery, but our recommendation was going with doing the upper endoscopy in high-risk patients. So we should consider the endoscopy expertise after reviewing our patient history, that the experience could affect the endoscopy result and findings, like in high volume centers that they have many patients that sometimes they could miss small polyps, especially if they have a training, if they are training center. And with screening endoscopy, they usually give it to, or they allow fellows to do the the endoscopy in general, so without supervision. So it can affect these screening values. High-risk patients also as well, we could label them as mandatory to go for upper endoscopy and also examination of resected stomach after surgery. There is one institution of the 17 cases which we mentioned before. They used to grossly examine the resected stomach after sleeve gastrectomy, and they discovered enlarged mucosa one time, and after that they sent it to histopathology, which confirmed the diagnosis of adenocarcinoma. So it's cost effective, and it doesn't take time. So I think it's worth opening at least the resected stomach and examine it grossly. At last, lifestyle modification after surgery is very important, especially people with who take high doses of caffeine and smoking, and people who present later with reflux symptoms. Okay, this is the end of my presentation. Thank you very much.
Thank you very much, Ahmed. If you can get the screen back, please. Thank you for the whole speaker and the panelists. We'll have like 5 to 10 minutes just go over the different videos from, if you can get panelists to comment on one of each case. The first case was the splenic abscess of Dr. Assam. If you can take Naif Al-Ainazi. Is Dr. Naif around?
Yes, I'm around.
Now, if you'd like to comment on that case, have you seen splenic abscess post-sleeve gastrectomy?
Actually, it was the first one for me to see like this. I remember I attended one of the cases that have been discussed in a few years back in SASMBS. But in my experience, I never seen like this before. It was a great job from Dr. Isam, and I hope the patient will continue his life as healthy as he can.
Actually, I had one case. It was a super obese patient who had band and complicated band. The band was removed, and then he had sleeve gastrectomy between me and Fahd and Dr. At King Faisal. After we removed the band, we did a sleeve, and the patient leaked, and his leak was like healed after 1 year, and 2 to 3 years down the line, he had an abscess in his spleen, and they have to take the spleen out with the abscess. But that's the case I am aware of in our practice. But I
have a question.
Fadl. Yes.
Sorry, go ahead. Sorry, go ahead, Dr.
Yeah, the patient ended by splenectomy, and he did well at the end after that. Complicated band, and then sleeve, complicated leak, and then splenectomy. The good part of that story, basically, he had maintained his weight after all that difficult time. Yes, Sam, go ahead.
Dr. Assam.
Oh, sorry.
Yeah, go ahead.
We got one case I remember in Quebec City during my training fellowship, 15 years post-surgery. And he got the same thing, cyst collection. Immediately we took him, we did a drain, CT drainage, He improved. He spent around 1 month with us with TBN, but we kept his spleen. So maybe the presentation of Dr. Islam's case, it's not a clear diagnosis at the beginning, as Dr. Islam said, but I think Dr. Islam handled it well and he managed it well.
Sam, what do you think the reason behind the fistula between the spleen and gastric flap? Do you think there was a kink or there was hidden leak or?
It was actually the beginning of the issue is the leak. And as I showed you in the systemic review, 11 cases of those 18 patients actually secondary to the leak. But the question that always, we know that the immunity system, especially in young patients, as in mine, which is around 22 years old, usually it prohibits any fistula formation or the infection really to grown up. We, even the immunity of this patient, she has been investigated thoroughly by our immunologist and everything, trying to identify if there was even something going on, conclude to that. And the late presentation, which is almost as you mentioned in your case and even in ours, and also in the systemic review, the mean timing, it's almost 120 days. That means delayed presentation. Most of those patients, they will have a delayed presentation.
But your gastric flap was fine. There was no kink or twist or?
It was very nice, and you can see it in the video. It was, and even the calibration tube moving very smoothly. The upper GI endoscopy, we did it twice, pre-op, and it was going very nicely without any issues.
Isam, just one question, please. Why did you elect to put a clips rather than just fire a stapler across it?
The first two lines, it was very small ones, and I was actually initially not convinced that this is the fistula, until I reach all the way up and dissecting to the gastroesophageal area upstairs, all the way up. Then I finalized it's only that line which was connecting to the spleen. I thought that it is very small one, the clip will do the job rather than to do the firing.
Isam, I have a question for you. First of all, a patient came after 1 year from the incidence, right?
Yes.
This is interesting and weird in the same time, because presenting a patient with splenic abscess after 1 year, I think there was an abscess, maybe since the fistula was created, let's say 2 or 3 months after the surgery, and it was collecting till reaching a year after the procedure. Why not intervening from the beginning? When you saw that patient, there was a suspicious of leak. Maybe he had a small fistula or a small leak that maybe the radiologist, depending on the radiologist, how he was evaluating the CT scan, and nobody discovered that, and you don't interfere at that time.
Thank you for that. Her first presentation, which was almost 1 month after the sleeve gastrectomy, there was a suspicion of leak, and she was admitted and she was treated as a leak, and she did very well with that conservative treatment. She was on a regular follow-up almost for 6 months prior to that second admission after the leak management, and she was doing very well. We had also her CT scan, which revealed normal spleen, and there was nothing at that time. After that 6 months, when she presented the first time, almost 1 year after her presentation, we found this new abscess. So I start not to correlate it initially, and I said maybe it is not related. And we treated her conservative with IV antibiotic because we failed with all workup to find any fistula tract or something explained. But after that conservative treatment, she came back again. So I thought, no, there must be something going on related to my surgery for the sleeve gastrectomy.
All right, thank you. We'll move to Hussam Maadi. Hussam, how can you avoid such problem? What's your advice? What's your message to the audience?
Yeah, this the prevention should be like what I did at the end. Actually, it always to be sure that you open your gastroscopy with your clasper, and so you are be sure that you're putting two edge of the stapler in the gastrostomy and the genostomy, and always to check your anastomosis from inside to be sure from whether it's bleeding or it's complete. This is actually very important. Not to depend that you are finished very quickly and that's it.
And what made you suspicious that things are not going well?
The reason actually when the surgeon was opening the anastomosis checking, I found fat pad between the two stapler line, which should not be there. The two mucosa should be only between the two staplers. This is the reason I stopped him from processing. And we check again and we found the actual gastrostomy is up and was intact.
Very good. Any question for Dr. Hussam from the panelists? Fawaz, do you want to ask any question for Dr. Hussam? Fawaz is not around. He gave up on us. Anyhow, thank you. It was very good actually and courageous that you present your such catch up. Next case, it will be Professor Mohammed Al-Nami. عاطف بصاص is around or not around?
إلا موجود.
طيب دي شغلتك. What do you think of the work of the Prof Al-Nami?
لا طبعا محمد يعني من الزملاء القدامى يعني I appreciate his work. I think يعني he did a good job. بس أنا عندي نقطة مهمة عبد الرحمن في الأشياء اللي كانوا الزملاء بيتكلموا عنها. The length of the alimentary limb and the common channel. I did some time with Mario Muselli in Napoli, and he advocates measuring the whole bowel length. And we were shocked, actually. He showed me in few patients that the bowel length varies between 4.5 meters up to 10 meters. So I think it's very important for us as bariatric surgeons to measure the whole length of the bowel. And if we are deciding to go for like 20-30% exclusion rate, then what is this 20-30% out of? Is it out of 10 meters? Is it out of 8 meters? Is it out of 4.5 meters? So I actually think that part of the failure of the surgeries that we are doing these days is because we are not having a good estimation of the bowel length. And therefore, sometimes we are excluding a part of the bowel which is not enough for the patient to lose weight. Therefore, I think this is a question for everybody to think about. And I have tried myself to pre-operatively do the measurement using the CT scan with barium and go myself and look with the radiologist, because you know the radiologist will not spend much time on this. They're looking usually for a leak or for whatever other reasons, but for them to measure the whole length, it's something that they don't like to do. But I think this is a major issue that we have to think in the future, how to measure the length and how to exclude, to be able to decide how much weight loss we are going to create in our patients. Thank you very much.
I think it's a very valid point. Prof. Nami.
The milestones of laparoscopic Roux-en-Y gastric bypass have changed over the years. At the beginning, we used to have a biliary limb of 75 and a Roux limb of 100, maximum 150. And with the time, the studies have shown that elongating the Roux limb is not that much beneficial. And brave surgeons were proving that elongation of the biliary limb recently has helped those patients. But again, as Dr. Atif Bassas mentioned, we have to measure the whole small bowel. Because if you elongate the biliary limb on the expense of the shortening of the common channel, you will enter the patient into the dilemma of hypoproteinemia and liver failure. So once you are, as you have heard tonight from Pershauer and from Delamans, that they used to keep the common channel on the revision of redo-gastric bypass from 100 to 250, even though those patients have suffered from hypoproteinemia and liver failure. So you have to, and the recent recommendation is to go 400 and more, not less than 400. So that's the current status of redo gastric bypass.
But you recommend that we should measure the whole bowel length in doing that kind of...
For revision, definitely. For the primary, maybe what I'm following now that for a BMI less than 50, I do 150, 150, both limbs. For BMI above 50, I do 200 biliary and 150 row limb.
So you consider BMI as part of the measurement?
Yes, yes. But for revision, you have to measure really because you're gonna shorten the common channel further, and you have to be careful not to be less than 400.
I'm seeing you shaking your head, Fao. You do have a comment?
Yes, I remember long time and always Dr. Abdurrahman and Mary discussing this manner and especially regard the residual and to measure it from the beginning and always to measure. As mentioned by Dr. Atif, there is a lot of variance between people. And if you don't measure it, at least make sure that the residual or of the common channel there is more than 300. And as mentioned by our senior in the lectures that now they are even say 400 because I remember they teach us that it should be more than 300. So always I am measuring in my cases, always.
Awad, do you have any comment on that bowel length?
Agree 100% with Prof. Nami, and I agree with Dr. Atif Bassas. It's really important for revision cases to measure the intestine before any revision. This is number 2. And as I mentioned, when I do now, I start to do elongation of elementary limb, but I see the result is not that great like the biliary limb. And this is the standard now, starting to go to elongation of the biliary limb. Not more than 250 to keep the common channel 300. As Prof. Nami said from his experience, he increased it to 400 just to keep patient away from risk of malnutrition. But we see good results actually. So measurement is really critical for any revision patient. And as a standard, we'll go after the measurement with the biliary limb of 250 based on, as Prof. Nami mentioned, the body mass index. When it's going higher, we go to 250. When we go lower than 50, we go with 200 around. As the case of Dr. Nami, he chose because he wanted the common channel to be more than 400. That's why he went with 200, not 250 with the biliary limb.
اسمح لي عبد الرحمن بس تسمح لي اقول كلمه اذا سمحت. Sorry to interrupt. Being as a liver transplant surgeon and during my time in Hamburg, I still remember 2 cases that we had to transplant after a Scobinaro. And believe me, those patients, they don't do well after the transplant. Even after transplant, they don't do well because of the severe malnutrition. None of their anastomosis healed properly. So I agree with Muhammad Nami. We have to take this very seriously. And for my colleagues, doing this measurement, it takes, believe me, it takes you around 15 minutes at the maximum. You either you start from the top or you start from the bottom.
That's right.
And you just go and do it. You know, Believe me, I have seen 4.5 meters, the whole length of the small bowel. If you take 1.5 or 2 meters from that, or as my colleague said, 4 meters, you're excluding, you are going into a short bowel syndrome. You are just repeating the jejunal-ileal bypass from before. So I think this is a major issue that we will probably in the future find a solution for it as bariatric surgeons.
And I think the solution is to measure. You have to measure, you have to run the bowel before you make your final.
15 minutes will not make you regret. It will really make you stand on a solid ground.
حيدر دكتور حيدر الشرف
معاكم
صاحي
تفضل.
ولا نمت خلاص؟ هخليه لغايه الفجر عشان تروح تصلي. طيب عندك اي كومنت على الباول لينث وعلى الميجرمنتس؟
والله انا يعني بعد الاخوه ما قالوه واثروا فيه، اعتقد الميجرمنت is a tool to prevent the complication.
That's true.
But we يعني as a surgeon now we realize how important is the measurement to prevent these complications. But from other side, I think in the primary surgery still there is a lot of factor in addition to the measurement can help you to prevent these complications. Because in the primary bypass, we don't do total measurement, and we don't most of these bypass. But probably in revisional is the one which is really crucial, because in those revisional people start to do elongation, and in the matter of elongation now the issue. Now, if you do Sugarman technique, which is elongation of pancreatic, or you pulling technique, which is to elongate the elementary limb, the variability according to the recent study that, according to Calvin Higa, is that if you prolong the elementary limb, the complication of malnutrition more. While Sugarman technique, in which you prolong the biliopancreatic, is less complication of malnutrition. Probably this is the only addition I can add to this.
طيب احنا will move to the next case, which is.
May I add one more important thing, Dr. Adwan?
كده هتصلي الفجر فعلا.
Yeah, just the for revision also, not to forget revising the gastrojejunostomy complex, because really our patients, they have different behavior of eating, and they ate large portions of food that dilates the stomach,
no doubt
and also the candy cane loop and the pouch. So if you leave it, even if you elongate the biliary to 400 or more, I think they will not lose that much weight as long as you have no restriction in that area.
يعني هذه إذا تسمح لي دكتور، أنا كانت في ذاكرتي بس عاد النعس والشيخوخة منعوا الذاكرة، لكن
you did it already يعني that's
يعني أنا أظن in all our bypass revision, the contrast study really does not reflect the real pouch. They don't reflect, because you know these pouch drain fastly in the small bowel. Then you cannot by image, you can say this pouch is that size or this size, or small or big. And really much of these bypass, when we go in, we see pouch is larger than the picture, what we see in the image.
Exactly as I have demonstrated, when we saw the barium, we thought this pouch is slightly dilated, and the candy cane lobe was not that much dilated, but actually when we dissected them, they were dilated.
We'll move to the next case.
Thank you.
VBG to Roux bypass. Omar, Prof. Omar.
Yes.
You do the same?
Yeah, exactly, and
you will not go for
enjoyed.
You will not go for VBG to sleeve.
No, I have done it actually in a couple of cases, but I think it's much easier and much safer for the patient to go for a bypass, especially when they use a mesh as a band. Yeah.
Naif, you would do the same? Naif, Naif, where are you? You are unmute your microphone, ya Naif. Naif is not around. Who would like to comment? Haider.
Haider he showed you the video.
You want to do it sleeve.
Yeah. I did 3 VBG into sleeve. 2 of them leave. So don't do it.
Don't do it.
I do, Dr. Haider.
So
what I do endoscopy and I see if it's wide and there is no reflux disease. I go intra-op, I pass my Fuji after removing all adhesions. And then I did many cases, I would say maybe like 20 to 25. They do well, they have no problems. I do the same technique like Dr. Haider did over so all, and they do well. But before that, I do endoscopy to make sure it's patent and it's wide, and the patient has no reflux at all. This is what requirement.
And do you want to make sure that the mesh is not eroded into the stomach when you do pre-op endoscopy. Actually, I agree with Awad. We have done a couple of them, but I still think what Dr. Haider did probably is the safest approach.
Hussam, what would you do? Hussam Adi.
Yes, actually, for VBG, I usually convert him for Roux-en-Y gastric bypass. Some we may convert to mini gastric bypass, but the majority actually for Roux-en-Y. We don't do for convert them to sleeve at all.
Actually, in 52 revision post VBG, 32 of them were to Roux-en-Y bypass in my series, and 18 was reversal, just reversing to the normal anatomy, and the other 2 were mini bypass and sleeve and all these trial. Even we tried to Scopinaro and super morbid obese, but I don't advise. And actually, in the literature, what they mentioned is the best revision for VBG is Roux-en-Y bypass. Secondly, reversal to the normal anatomy with the expectation of regain of weight. These are the two way of revised VBG. I think in the practice, I have seen it as a safe way.
And most of my cases actually VBGs, I do a sleeve on it. I remove either the band or the mesh, and I do sleeve. And so far, so good, alhamdulillah, we have good results. I don't recall the weight loss, but that's what I'm doing actually. And in some cases, we did on top of the sleeve, we did the SASI. We do the remove the mesh and do the sleeve, and then we hang up the stomach to small bowel or jejunum. That's what I'm doing actually. It's sort of a different bypass or sort of another kind of bypass.
لأنك أنت الأحسن.
لا أنا بدال. I'm saying that's my experience يعني أو that's what I'm doing.
يعطيك خير البركة.
الحمد لله ما حصلش ليك يعني الحمد لله so far يعني.
الحمد لله.
Maybe I should collect these cases and present it as well. Sam, do you have any comment before you go to the next scenario?
No comment.
كان اسمي طالع بس أنا معلش.
أنت كنت رحت فين يا حاج أنت؟ مين قال لك تنام؟
Regarding the question, I had one case, VBG, it was converted to Roux-en-Y gastric bypass. I remember that case, I had the bleeding, severe bleeding. I injured one of the major vessels. So at the same time, I just converted to open because the visualization was not that good. But alhamdulillah, it was went smooth as a Roux-en-Y.
Very good, alhamdulillah. Next case is Dr. Awad Gahtani, and I think he did an elegant job, and he avoided malnutrition in a very elegant way. فاني comment from Prof. Nami?
Yes, it was a really good approach. And this has really corrected his previous problem. What I'm afraid in the future that his gastric pouch will enlarge more and the stomach will enlarge more and maybe he will regain weight. But let's hope that this will not happen. And if I were him, I would have resized the gastric pouch, at least from the lateral aspect and make it more narrow to be over 36 French calibration tube.
I agree with you, Prof.
And I think I disagree because the patient, you are doing a damage control here. You are doing a damage control and you would like to get the hook, the patient out the hook of malnutrition. If he regained weight at that time, you have the liberal to do what you would like to do. But I think you did the right thing. You know, adding more, you can go in more malnutrition. Anyhow,
I agree with Abdulrahman. I think you did a great job, Awad. I wouldn't resize. The main problem was malnutrition. I don't think resizing will help this problem. I think it will make it worse.
What I understood from Dr. Awad, he regained weight, isn't it?
No.
He lost 9 kg.
47 BMI?
No,
it
he
was
normal
28,
weight.
20, like 7, 26, and he lost around 9 kg. So he's good. But I agree with you, Prof. Nami, maybe in one condition because his age is 23. So he, like, you know, at the age of 40 or 30, you know. But it's a controversy. It's a controversy. Maybe I should do it, but if I'm worried about if you regain weight in the future, I think it's good to do it. As Dr. Abdulrahman mentioned and Prof. Ahmad mentioned, at the time of surgery, he's focused on the malnutrition. He's saying that I can't go with my friend outside because I had diarrhea. He's saying I can't go to my university. So this the main target we are focused on, and we had a good, excellent result. And also he lost around 10 kg, so that's good result.
Atif, would you have done the same or you have done something different?
No, and I agree with you, Abdurrahman. We have a big problem, which is malnutrition. This is something we have to tackle. We have to finish it. This is a dangerous. Again, I'm telling you, I'm a transplant surgeon. I see these patients in the bad side. So even if he's, with my due respect, Muhammad al-Nami, even if there is a chance for him to weight regain, I wouldn't really think about it twice. My main concern is to finish this issue with the malnutrition, because Scobinaro is a very short common channel, and we know that this procedure was really downsized, or at least people start to stay away from it because of the frequent cases of malnutrition and liver failure. So I would take the same attitude like you said, tackle his malnutrition, make sure that he is okay, and then in the future give him the liberal to use any other procedure he might need.
حيدر راح يصلي في القلب.
راح يأذن.
أين أنت يا حيدر؟ خلاص طيب عصام عايز تحط حاجة أو حسام؟ Do you want to comment?
Actually, what he did is very well. Yani, I totally agree with what he did. It was a great idea. I would not do further. I will tackle his malnutrition because this is what will change his lifestyle.
Very good. هو يعني last case, which is I think is the most important pending issue, which is a cancer on top of sleeve gastrectomy. Who would like to address that issue? عصام يلا أنت اللي على الشاشة.
If you allow me.
يلا go ahead.
I present twice 2 cases that in the resected part of the stomach we found the cancer. Most of the time it found incidental finding without any
Can I interrupt you here for a second? That's the resected sleeve.
Yeah,
صح؟
the resected sleeve.
Most of us are not sending the stomach to pathology. And I think we should take the podium here to say that's wrong. Any tissue gets out of the patient should go for pathology. Please.
Dr. Abdurrahman, all the literature is not supporting this. They did many studies.
عصام اهو قدامك بيقول two cases. بس هو طبعا انا قبل ما نقول كده احنا should we يعني انا I think الافسو ستيتمنت اللي هي كانت 2020 كانت بتاع ويندي براون ان هو it's a must or يعني it should go all of us should go for pre-op endoscopy. and I think that's maybe would be يعني cut it short يعني مش بس السبيسمن ناخدها لا احنا الاندوسكوبي كمان should be done. go ahead Assam, sorry for interruption.
I would recommend all my colleagues, and this is what I'm doing, to inspect that part, the resected part. If I saw anything suspicious on that stomach, I usually take a stitch and send it for the histopath. We know that it is different between, it will add the cost of, I think, around 800 riyal between the private and governmental sector, that it will be additional on the cost and something like that. But at least, if you can please just inspect it, and if you have any suspicious in it, that you have to send it for officially for histopath.
طيب back to Awad.
So I agree with Dr. Issam, and I agree with you, Dr. Abdurrahman, because endoscopy is really for selected patient. I think it's really a must pre-operative for any patient who has reflux disease or any GI symptoms. This is number one. Number two, I agree with Issam. If you have a specimen and there is some abnormal finding, it's really a must to open and send it for pathology. But to send all the specimen to the pathology, I did my literature review and I found all the studies not supporting, because they did it and they found it's like 1 or 2% maybe there is something in the specimen. This is, I think it's hot topics now in bariatric surgery, because there is some studies saying that sleeve gastrectomy is increasing the incidence of esophageal cancer and gastric cancer, but we didn't see anything as a real and a strong study.
يعني from my experience actually at least 30% would show H. pylori, at least. That's one. The second one is, and I haven't seen in the because we are sending all our specimen to pathology. I haven't seen a cancer. I haven't seen other pathology. But from the endoscopy, which in that paper of Wendy Brown, there was like 17% they have to delay surgery, and 2.2% they have to cancel the operation because of dysplasia or whatever. And I think you have a tissue. That's why in my training in McGill, any tissue has to go to pathology. We are not pathologists, we are a surgeon. And it's their job to decide, yes, we just do it gross or we go for more than gross examination. Any comment from Naif or Hussam or Atif or Haidar?
I have one comment. Actually, as all of you said that agreed on individual, selected patient going for upper GI endoscopy preoperatively. I have one patient, incidentally, during sleeve gastrectomy, when I reached up, finishing all the resection, I found there is a huge mass. I thought it was a patient he's eating food, or something else. Anyway, after taking the specimen out, I opened the specimen. It was a huge mass. We sent it for pathology. It came as I guess, tumor that located in the fundus. Thanks God, it was mainly located in well capsulated and located mainly in the fundus and the resected part.
And I had like 3 or 4 cases of migrated pancreatic tissue. That is picked up in pathology.
The question is now, patient. Sorry for Dr. Omar.
Go ahead, Dr. Naik, please.
The question is, I remember the patient when I go deeply, pre-operatively, when she came to the clinic, there was no history of any issues. And when we go deeply in the history, there is no any symptoms, any signs for any gastric illness. That was weird post-operatively when I saw that, intraoperatively when I saw that mass inside the stomach. So the question, shall we go really to go for investigate all the patient or no? For me, I was doing that in selected patient according to the history of the patient, if they have any issues in their stomach. Otherwise, we will go directly for non-endoscopic evaluation.
Well, question we should answer the whole panelists here. Should we do a routine endoscopy? And that was a recommendation from the EFSO statement. Do we agree on that issue of pre-op endoscopy?
Actually, I'm doing routine. I'm doing routine endoscopy. I'm doing myself for all the cases.
Prof. Nami.
The recommendation is to do, but the feasibility is an issue here.
Very good. Assam.
The same as Dr. Hussam Uday said, I am doing also my endoscopy cases, but still now with a huge number, I cannot accommodate all of those patients to be done as endoscopy, even with our colleague with the gastro. So we start to be selective.
On Taiwan, it was being done on table, and before they go for surgery, they do it on table, and accordingly they decide about type of surgery. I don't know if anyone would. Yeah, please.
محمد بوهب معك دكتور عبد السلام عليكم.
محمد كيف حالك؟ السلام.
أيوة هو just to comment. First of all, when you said when you were in your training in McGill, if this tissue has to be sent to pathology, we used to send even the foreign body. If it goes by science, every single tissue has to be taken from the body, has to be sent, even lipoma. This is the ethics, but visibility is a problem here, especially in private. The second question regarding either endoscopy or not, I mean, lots of rhetoricians are supporting routine endoscopy in every single bariatric procedure. What I do in my practice, I do selective endoscopy based on patient presentation and symptoms and type of procedures, it's revisional or not. But I do routine abdominal ultrasound and routine perineum swallow for all patients, primary, revisional, not. And I picked a lot of patients who had just a tumor or gastric ulcer that needed endoscopy after the barium. And I picked a missed or maybe being treated or being asymptomatic large pancreatic pseudocyst that made me just stop doing the procedure or booking the patient till get treated from the pancreatic side. So at least if you're not doing routine endoscopy, I would recommend or I would suggest do at least a routine abdominal ultrasound plus barium swallow. Thank you.
But Abdurrahman, I just have one comment. I do, as Dr. Nami said and Dr. Naif, I do selective pre-op. But what my question now is for post-op. Do we have to do a routine surveillance every few years or no? And I think my answer is yes. We should encourage patients to do a routine surveillance every 5 years at least, in my opinion.
Yani the EFSO statement actually about endoscopy pre and post, they recommend the pre-op routine and post-op every 2 to 3 years, especially if the patient is symptomatic. That's the EFSO statement. Now, how can we do it with that problem of insurance? And even the blood workup, the insurance gives us hard time for to doing the routine blood workup. I think it's a matter of surgeons should do their own routine endoscopy with patients, and in Shemesi, في الشماسي, Haitham Flah did a very good job, and all patients should have routine endoscopy pre-op. I think it's part because you will find that at least 30% according to that study, would need kind of treatment prior to their surgery, either H. pylori, either gastritis, or the hiatal hernia, small hiatal hernia, large hiatal hernia. And I think it should be part of the routine workup. Knowing that the sleeve gastrectomy is a reflexogenic operation and it can end with one of these miseries. Allahu Alam. And I would like to end the session. It's 1:30 already. Before we end the session, the last speaker here is the Prof. Nami. Would like to update us on the fellowship program coming out from our جمعية اللي هي Saudi Society of Metabolic Bariatric Surgery. Prof. Nami, are you around?
Yes, I'm around, but I started seeing more than 200 participants. Now 89. I wish that the majority were there to hear the update on this issue. So do you like me to continue or postpone it?
You can do it tomorrow if Aid Gahtani would approve. And I think the update is important. If and I started our session by 1:60. Now we are
condition that I'll be the first one.
Tomorrow I have to speak to Aid, and Aid is a big boss here. And I support that. Aid is not around. Aid, most likely he's going to sleep as well.
May I just comment on one issue here, the GERD after sleep. The symptoms really has to be considered seriously. Those patients who are symptomatic and booked for Roux-en-Y gastric bypass should be done urgently, not on the wait list, okay? Because the development of dysplasia and cancer might be an imminent issue as some patients will develop this compared to others who are resistant to metaplasia or dysplasia. I have one patient waiting for 1 year for her surgery, and she developed dysplasia. Luckily, we caught her before it develops to cancer, and we ablated this and then proceeded with Roux-en-Y gastric bypass. The scenario presented tonight that the patient developed esophageal gastric carcinoma is because the delay of management and the long wait list is not an excuse. That's the point I want to make.
طيب عملت الاندوسكوبي ولقيت بارت or لقيت يعني changes because how frequent you will follow the patient? Or
I refer them to my best gastroenterology friends who can take biopsies from these areas. And then they will tell me how bad is the disease. And we should consider those as an urgent cases, not elective.
Would you switch him to bypass if you find Barrett?
Definitely.
Or you will do serial endoscopy?
There are two scenarios. One scenario that the patient is improving with PPI. Those patients should be followed routinely by the gastroenterologist and take biopsy every 6 months. If any dysplasia develops, then it has to be ablated and they go for surgery. Those patients who have moderate to severe GERD and or severely symptomatic, even if they use PPI, I think those are urgent cases that needs a Roux-en-Y gastric bypass, not to be delayed.
How do you do the
even
same?
For the quality of life?
Awad.
Yes, I do the same like Prof. Nami. So I do endoscopy for them if they have symptoms. I found Barrett's esophagus. What's the biopsy result, metaplasia or not? If patient doing well with PPI, then we'll continue observation. But if the patient is coming to you while he's asking for bariatric surgery, then sleep is not there. We go for bypass immediately.
Very good. And I think all the attendee and we went down to 85 attendee now, and most of the panelists have gone as well. and I think it's time. It's 1:30, after 1:30 actually. I'd have sent a message saying that for Dr. Nami or Prof. Nami to present his talk after the session of endobariatric, after the endobariatric session tomorrow, about 10:30. Is that okay for you, Prof. Nami?
Yes, definitely.
I'd like to thank all the speakers, all the panelists, all the attendees who stayed out till after 1:30. I think it was fruitful presentation and discussion, and we'll hope we'll continue tomorrow, and we'll have the same quality of presentation and discussion. Thank you all. Thank you, Aid. Thank you, Prof. Oh my goodness, I lost.
Good night.
Good night everybody. تصبحون على خير. السلام عليكم.
بس هو البروف الشيف بتاعنا الدكتور مفتي يعني very thanks for his presentation. It was an excellent presentation يعني. Thank you all.
تصبحون على خير.
تصبحوا على خير. شكرا عصام. مع السلامة.